Mr. Tarun, shall we start?
Yes, sir, we can start now.
So, good evening, everybody. After a good first day, today we will continue with prostate session, and I will welcome Dr. Ajay Bapna, sir, Head of Department Medical Oncology at Bhagwan Mahavir Cancer Hospital, Jaipur, and I will request him to set the ball rolling.
Yeah, thank you, Rishabh, and all the friends. Good evening to all of you. So today we are in day 2 of GU Conundrum, and we saw the unprecedented success on the day 1 of GU Conundrum. And why there was a success, because of the intricately selecting the topics as well as the abstracts and also the faculty. So the all the hard work done by Dr. Tarachand and Dr. Asim Samar was quite, we have all witnessed it. So there was a lot of honesty and sincerity in selecting the topic as well as the faculty. I think we are going to repeat the same on the day 2 of GU Conundrum, and we can start the program without wasting much time. And over to Dr. Rishabh.
Thank you, Bapna, sir, for kind words. Now we will start the session. I would like to invite Dr. Sandeep Jasuja, sir, Medical Superintendent, State Cancer Institute and Head of Department Medical Oncology, SMS Hospital, Jaipur. I will request sir to chair the session and invite the speakers.
Very good evening, all of my dear friends and colleagues. And at the outset, I would like to congratulate our young budding oncologists of Jaipur. And really, I'm thankful so that they have given me an opportunity to interact with our other friends and colleagues. So, not taking so much time, now this is the time for prostate cancer, localized prostate cancer discussion. And we have very eminent and good faculty with us to enrich our knowledge and our clinical importance, and also new drugs, whatever new trials and studies are in a non-metastatic prostate cancer. Now we will have 5-6 eminent speakers, and first I invite Dr. Rahul Krishnarthi. He is the Associate Professor of Department Radiation Oncology and Specialty Uro and Neuro Oncology, Tata Memorial Cancer, Mumbai. So, Dr. Rahul, over to you.
Thank you for your kind invitation and introduction. So yeah, this is the first abstract for the day, which we are going to discuss is basically adjuvant radiotherapy following radical prostatectomy for localized prostate cancer. So it is a systematic review and meta-analysis presented by Bortel et al. From Brazil at ASCO GEO Symposium in January 2020. It was presented as a poster. So yeah. Now, why did they do it? So they did it because there are 7 trials right now which have been conducted in this for this particular question, and still probably we have a lot of confusion whether adjuvant radiotherapy helps or not helps, or when it should be. So that those are the pertinent questions. And so the primary endpoints that the authors looked in their meta-analysis were biochemical progression-free survival, metastasis-free survival, prostate cancer cause-specific survival, overall survival, and the side effects. So if you look at the results that they had presented in this abstract, was basically they showed improved biochemical progression-free survival significantly with adjuvant radiotherapy as compared to the expectant treatment. Now, just to clarify, what is an expectant treatment is you just observe the patient, and suppose there's a PSA rise and you are certain that there's a clinical or radiological progression, then you treat those patients locally or systemically as required, right? And so if you do that expectant management, the biochemical progression-free survival is not good, and it's significantly improved if you upfrontly do adjuvant radiotherapy, especially in the high-risk patients. Now, metastatic progression-free survival is also significantly improved, but what you see is cause-specific survival or overall survival is not significantly improved. Now, another point to note when you look at all these results is basically there was a significant heterogeneity in meta-analysis patients that they were taken from the 7 trials. And they did try to balance it out using random effect model analysis, but results still remain in favor of adjuvant radiotherapy for the biochemical progression-free survival. The rest all they have not commented in their abstract, so we don't know. We don't have the full paper available to understand what happened to the other endpoints. So what they have concluded in the abstract is this is the first meta-analysis including the 7 available randomized trials, and adjuvant radiotherapy statistically increases the biochemical progression-free survival and metastatic progression-free survival, but did not have an impact on OS and cause-specific survival. Now, taking the discussion a little deeper to understand what is happening, because you will see in last 6 to 8 months, 2 or 3 meta-analysis coming up. This Brazilian group has presented in 3 conferences, and all the 3 conferences it was treated as a poster. Before that, Artemis one was there, which was a podium presentation in ESMO also, and other Astro and other conferences as well. So why this apartheid or kind of result? Because there's a difference between the 2 meta-analysis and the results that they're presenting. So let us look at first what are the baseline 7 clinical trials we have. So the ones with the red on the right hand of the slides are basically the historical ones, and you can see the dates between 1990s to 2005 they were conducted, and eligible criteria is almost similar, except that it is mainly margin positivity or pathological stage 3 or above. Right now, dose of radiotherapy is almost similar. The main thing that you have to understand that these all 4 trials, it was basically adjuvant treatment versus expectant treatment, which I just said to you. Now, when you read individual trial of these, you will see that around 30 to 50% of their patients, depending on each trial, received salvage radiotherapy or later on the observation arm. And that radiotherapy was given around the PSA, median PSA of value of 1, right? So this is important to understand when we talk about the newer trials, okay? Now, primary endpoint in each trial was different. So EORTC is progression biochemical free survival, the SWOG is metastatic free survival, ARO is PFS, and again finishes biochemical progression survival. Design is almost similar, so let us take it as similar. We don't differentiate there. But if you look at the key results, what we know of today is both EORTC and SWOG showed improvement in the overall survival, but ARO and FINISH did not. And if you look at the sample size, EORTC has the maximum number of patients, which are 1,000 patients, as compared to, it will add up to rest remaining 3 of the trials. Now, what are these newer trials, or which are in the white or left side of the screen? These are the recent trials. They have just finished accrual. We do not have their long or even short-term outcomes available in literature as a full paper. What is available is basically abstracts presented from the radicals RT, and we have an Artemis, this meta-analysis, which comprises only 3 trials, which was actually pre-accrual. They got together and said that we will pool the data of the 3 trials to look at the long-term outcomes of progression-free survival and OS, because individually these trials may not be able to answer that. The second difference we have to understand is the 2 of these trials having an ADT additional to hormone therapy additional to radiotherapy also. And the third is they are not basically comparing expectant treatment versus adjuvant. They are comparing adjuvant versus early salvage. So in expectant treatment or the older trials, they were given, around 1 or 2 as per the, local tradition of that place where the trial is being conducted. Whereas in these trials, there are specific endpoints of PSA which are achieved, which is 0.1 or 0.2 is the value when you give an adjuvant radiotherapy or salvage radiotherapy. So there is going to be a difference between the outcomes as well as the kind of approach you will get. So what we know from the radicals abstract that was presented in ESMO was biochemical progression-free survival also is not different when you do a early salvage versus you do a adjuvant radiotherapy for all. And that the separating line becomes basically the toxicity, because if you're giving everybody the radiotherapy, the number of people getting toxicity will be higher as compared to when you're just salvaging 30 to 40% of the patient. So till now, at 5-year median, only 30% of the observation patients or the early salvage has been given to them. Rest 70% have not needed the salvage radiotherapy. So this is one of the older meta-analysis which included the first 3 older randomized trials. And what you see here, another important point is improved survival outcome is at 10 years, not at 5 years. Similarly, cost-specific survival and the metastatic disease-free survival also improves at 10 years of follow-up median, not at 5 years. Whereas local control and biochemical progression-free survival improves at both 5 and 10 years of follow-up. So this is a Cochrane meta-analysis of older 3 trials. What you see again in the pictorial form. So we have to be careful when we are taking the newer trials and pooling the data based on the abstracts presented on various meetings. So that data or that outcome has to be taken with a little pinch of salt. So this is what the Artemis is saying that I was saying presented in ESMO for the newer trials. And what you see is adjuvant radiotherapy is almost same for biochemical free survival in versus the early salvage RT. So based on this, again, just to review whatever I have said, so that there's no confusion and there's more clarity, that the newer trials have RT plus adjuvant hormone sub-randomization as well. So we need to know when people are doing the meta-analysis or their analysis, we need full paper to understand which patients have been taken and which have not been taken. Early salvage is better than the observation, probably which was followed in the older trials, and long-term survival and long-term outcomes are much more needed to be more sureful about the results of either the old timers or the new trials, and then make a conclusion about the outcomes rather than these small spurts of abstracts which will keep on floating for next 5 years, I suppose, till we have a very large database of 4,000 patients with stringent meta-analysis. So to conclude, I would say guidelines still recommend adjuvant radiotherapy because the raves or radicals outcomes are not available in public domain with the full published papers. They have not been peer reviewed, and the meta-analysis based on the abstract will be very difficult. Longer wait is, I think, will be necessary and prudent to and the way forward. Thank you.
Thank you, Dr. Rahul. I will request Jasuja sir to introduce the next speaker.
Sure. Thank you, Dr. Rahul, for a nice presentation. And now I would like to invite our next speaker, Dr. Rajiv Sood. And Dr. Rajiv Sood is a senior consultant, AVBIMS, and Dr. Ramanohar Loha, RMS Hospital, Delhi. And he is also President, Genitourinary Cancer Society of India. Dr. Rajiv, it's over to you, please.
Thank you very much for this invitation, and I will be presenting. Can you see my slides? Am I audible?
Yes, sir. We are able to hear you, but I'm not still able to see your
Am I
screen.
audible?
Yes, sir. We are able to hear you, but we are not still seeing your slides.
Can you hear me?
Yes, sir. Now your slides are also visible.
But I have shared the slides.
Yes, yes. Sir, we are able to see it now.
Okay. So this is today I am presenting the results of the state. You are able to see. Okay. So I am presenting the results of oncological results from the music statewide collaborated as presented in AUA 2020.
Hello, Dr. Sood, sir. Hello, Dr. Sood.
So there are internet connectivity issues at Dr. Sood's place. He's not at his place. He's in Himachal. So till the time his internet connection
Can we have
gets
the next
better,
speaker?
yeah,
Sir,
we can have.
can we have the next speaker, please?
Dr. Sandeep, sir.
Yeah, sorry
Yeah.
for
We can start with next speaker.
Yeah, for the next, we can continue with the next speaker, and later on, Dr. Rajiv, whenever he is available, he will join us. And so for next presentation, I would like to invite our next speaker is the Dr. Gagan Saini, and Dr. Gagan Saini is Associate Director Radiation Oncology in Max Super Specialty Hospital, Vaishali. Dr. Gagan Saini, please go ahead.
Okay, I think you can hear me now. And can you see my slides as well, please?
Yes, sir. We are able to hear you and we can see the slides.
Okay, okay. Thank you, Dr. Sandeep and Dr. Tarajan. I mean, this promises to be a very nice discourse, and I would like to present today the 8-year outcomes of phase 3 randomized trial of conventional versus hypofractionated high-dose IMRT for prostate cancer, the CHIP trial, CHHIP trial, which was published in Lancet. And this is the update from the CHIP trial. I'm Dr. Gagan Saini. I'm part of Max Institute of Cancer Care. So we go into the background, and then we will, start with what is the crux of the presentation. The CHIP trial is a non-inferiority trial that was designed to determine the efficacy and safety of hypofractionated RT. The trial's previous 5-year results were reported in Lancet in 2016, and where they had compared 74 in 37 versus 60 in 20 versus 57 grade. And they found that this 60 and 74, they were not inferior to each other, and 57 and 74 were not inferior to each other, whereas 57 and 60, 57 was inferior. So that is why 60 and 20 is was the proposed standard of care. The results were 5 years. We come to the third bullet point. Moderate hypofractionation is now an international standard of care. I'm sure my radiation oncology colleagues will agree that many of us are using moderate hypofractionation. But with patients remaining at a risk of recurrence for many years, the information on long-term outcomes is also very important. While CHIP trial does establish non-inferiority in terms of 5-year results, the long-term outcomes are also important, and that's what is being done in this presentation. A pre-planned analysis of 8 years was recently presented in ASCO. Between 2002 and 2011, 3,000 odd patients with node negative T1B to T3A localized prostate cancer with risk of seminal vesicle involvement of less than 30% were randomized, 1:1:1. Couple of important things. If you wish to practice hypofractionation, please remember that T3Bs were not taken, and also seminal vesicle involvement of less than 30% was not considered. So these were the 3 schedules. This is something I've told you about: 74:37, 16:20, and 57. Androgen deprivation was done, and at least 3 months prior to radiotherapy, and continued until the end of RT. On an average, patients got 6 months ADT. Some of them got 150 milligrams of bicalutamide, and some of them got the usual ADT, the LHRH analogs. The primary endpoint was time to biochemical failure as per the Phoenix guidelines, that is NADR +2, or clinical reasons. The non-inferiority design was specified at critical hazard ratio of 1.208 for each hypofractionated schedule. So that is what is the hazard ratio which they had fixed for any non-inferiority. Late toxicity was assessed at 5 years, and that is what is presented in this trial even. And this trial, as usual, was an ITT, intent to treat. So before we go to results, I'd just like to brush up on the fact that most of the patients in this trial were intermediate risk patients, and there were about 12% high risk patients, and those 12% high risk patients were then later upscaled to 19% when they did a central pathology review. So about 20% high risk patients, and rest were low or intermediate risk, and all of them got 6 months of ADT. So this is one of the things which, so this results, and they gave only prostate only radiotherapy, just for, practice clarity's sake. So we come to the results. Median follow-up was 9.2 years, and 8 years biochemical failure-free survival were, given in table 1. So this is the table 1. And you can see that the biochemical failure-free survival are, similar to each other, and the differences are not statistically significant. The 8-year results were essentially the same as 5-year results, confirming non-inferiority. So even at 8 years, the non-inferiority is confirmed. The results of secondary endpoints were similar as well. 176 patients developed metastasis over the course of study, and metastasis-free survival was 95.6, 95.3, and 94.8 in 74, 60, and 57 gray group, respectively, not 59, this is a typo. There were 567 deaths, which were, overwhelmingly by non-prostate cancer mortality, which brings me to the point made by my very lucid previous speaker, that overall survival in prostate cancer is very, very, confusing. Definitely cause-specific survival is the way to go. And so as far as safety is concerned, clinician assessments of late toxicity were similar across all groups. You can see that the late toxicity is not very high. Often it is discussed, this late toxicity in radiotherapy, in many forums, and this is a combined fora of urologists and radiation oncologists and medical oncologists. So this is the bowel toxicity and bladder toxicity rates. They're less than 2%, and even with hypofractionation or with regular fractionation. So this is the last slide. The conclusion is that biochemical failure rates of over 80% and long-term follow-up confirms that 60 and 20 is a non-inferior regimen to 74 and 37. And late side effects were very low across all groups. So these results support that we can continue the use of 60 and 20 as standard of care for men with localized prostate cancer. I thank you for your time. May I just add a practice point from my experience, that please don't use 60 and 20 in patients who are having a high IPSS, because when you have a high IPSS, this edema, which is induced by a 60-in-20 regimen can lead to a little morbidity, and we don't want our patients to be getting that morbidity. Some patients even get bladder outlet obstruction. I thank you for your invitation and time.
Thank you, Dr. for a nice and brainstorming presentation. And thank you very much. So not taking so much time because already we are getting little bit late. I would like to invite our next speaker, Dr. Amol Dongre from Nagpur. Dr. Amol Dongre is the consultant medical oncologist, LHS Multi-Specialty Hospital, Nagpur, and will speak on trial results from Sept. And Dr. Amol, please go ahead.
Hi, am I audible? Hi, am I audible?
Yes, sir, you are audible.
Just sharing my screen. Yeah, so thanks Asim and thanks Dr. Tarachan for giving me this opportunity. So I'll be talking about the final overall survival from PROSPER trial, a phase 3 randomized double-blind controlled trial, double-blind placebo-controlled trial, enzalutamide in men with non-metastatic CRPC. So we have already saw that the initial results of metastasis-free survival, and now this is the final overall survival analysis. So the median bone mets-free survival among men with non-metastatic CRPC ranges from 25 to 30 months, and the risk of mets is associated with increased PSA and a PSA doubling time of 10 months or less. So metastatic CRPC is fatal with median survival of approximately 3 years. Delaying time to metastasis is clinically relevant and may delay cancer-related complications. We know that enzalutamide, it binds directly to the androgen receptor and inhibits the binding of androgens, androgen receptor nuclear translocation, and androgen receptor mediated DNA binding. Its effect on overall survival has been shown in 2 international phase 3 trials involving patients with metastatic CRPC before and after the receptor of docetaxel. So this phase 3 PROSPER trial had previously demonstrated a statistically significant, clinically meaningful improvement in metastasis-free survival with a in men with non-metastatic CRPC and rapidly rising PSA. This we have PSA who receives enzalutamide, right? So when first reported, the OS data was immature with only 28% pre-specified deaths. So the final OS analysis of the phase 3 PROSPER trial is recently reported at the virtual ASCO annual meeting 2020, abstract number 5515. So in this trial, men with non-metastatic CRPC having a PSA doubling time of less than 10 months and PSA of more than 2 nanogram per ml at a screening continued androgen deprivation therapy. Hello? Yeah. And were randomized in 2:1 to Enza 160 mg or placebo. The OS treatment effect was assessed using a group sequential testing procedure with O'Brien-Fleming type alpha spending function. And medians were estimated using Kaplan-Meier method, 95% confidence interval using a stratified cost regression mode. So you can see the study design. Patients with non-metastatic CRPC and PSA doubling time of less than 10 months were randomized in 2:1 to enzalutamide 160 mg once a day plus ADT versus placebo plus ADT. So the primary endpoint, we already know it's a metastasis-free survival. The secondary endpoints include safety, time to progression, time to next therapy, OS, PSA response, and quality of life. These are the baseline characteristics of patient in where we can see that in both the arms, baseline characteristics are well balanced. So we directly come on to the result with a data cutoff of October 15, 2019. The median follow was approximately 48 months. There were 466 and 178 deaths in Enza and placebo arms respectively. So it is almost 31% deaths in enzalutamide arm and 38% death in placebo arm. So you can see that enzalutamide significantly prolonged OS compared with placebo with a hazard ratio of 0.73 and p-value significant. So the median OS was 67 months in enzalutamide arm and it was 56.3 months in the placebo arm. Subsequent antineoplastic therapies were initiated after treatment discontinuation by almost 33% men in enzalutamide arm versus 65% in the placebo arm. Now this is something which is very important, that even after treatment discontinuation, almost 65% of the patient in the placebo arm. Yeah. So these are the Kaplan-Meier survival curve. So you can see that patients on enzalutamide arm, they have a median survival of median overall survival of approximately 67 months as compared to 56.3 months with hazard ratio of 0.73. So median duration of treatment was 33.9 months in the enzalutamide arm versus 14.2 with placebo. More than grade 3 adverse events were reported by 48% of the men in the enzalutamide arm versus 27% in the placebo arm. And out of which almost 16 versus 6 were drug related. Adverse event with event rate less than rates per 100 patient year that were more than 2 points higher with enzalutamide versus placebo were falls, fatigue, and hypertension. So no doubt this falls, fatigue, and hypertension were more with enzalutamide arm. So you can just see this key safety outcomes wherein there's more than grade 3 events were little higher in the enzalutamide arm as compared to the placebo arm. So to conclude, this enzalutamide was associated significantly prolonged OS versus placebo, 67 versus 56.3. Enzalutamide treatment resulted in statistically significant 27% reduced risk of death compared with placebo, demonstrating that initiation of enza plus ADT before the onset of detectable metastasis improve OS in men with CRPC and rapidly rising PSA. This OS benefit was achieved despite crossover from placebo arm to enzalutamide arm and high rates of subsequent antineoplastic therapies in men from the placebo arm. So, this final OS analysis from PROSPER provides prospective validation of metastasis-free survival as a potential surrogate endpoint for OS in non-metastatic CRPC and support the continued use of enza plus ADT as a standard of care in men with non-metastatic CRPC and rapidly rising PSA. Safety was consistent with previous trial. So, if I have to conclude about this trial, it was an interventional double-blind randomized placebo-controlled phase 3 trial. Enza plus androgen deprivation therapy led to a 70% lower risk of metastasis or death and 22-month delay in development of metastasis as compared with placebo. There's increased toxicity in enzalutamide groups with more fatigue, fall, and fractures. There was also increased cardiovascular events and death, even though the study excluded patients with clinically significant cardiovascular disease. So, the clinical question in this PROSPER trial was to whether to start therapy in patients who have rising PSA level as the only manifestation of disease worsening with no disease on imaging. So that is something this clinical question in this PROSPER trial, which they need to answer. And this question was answered in trial for early versus late therapy and improvement in all secondary endpoints despite subsequent line of therapy. The increased adverse event as related to falls, seizure, and increased cardiovascular event require mention. And benefit is also unproven in patient with longer PSA doubling time because they have taken, they have a defined PSA doubling time, right? So, enzalutamide for non-metastatic prostate cancer represent important step forward for men with rising PSA level during androgen deprivation therapy. And the benefit risk evaluation suggests that treatment with either drug is better than waiting until the appearance of metastasis. But before I conclude my talk, I just wanted to know from the house also. Now there's a real confusion which drug to prefer in non-metastatic CRPC. We have a PROSPER trial wherein enzalutamide is the drug. We have a Spartan trial for apalutamide. We have Aramis trial for darolutamide. And we also have an Imagine phase 2 trial for abiraterone. With this, I just thank my organizers for giving me this opportunity. Thank you very much.
Thank you, Dr. Amol, for a nice and lucid presentation. And really you have taken it in a nice way. And the question what you have raised is really, we have to think of about this, what should we choose and what should not be chosen according to the patient convenience and toxicity and cost factor also is very important in the Indian setup. So thank you very much again for your
Can I ask one question to Amol?
Yeah, sure.
Right.
So the seizure disorder is often being overestimated in patients who are on enzalutamide, but as per the data from the trial, it doesn't seem to be that problematic.
मैंने खोल ली हैं स्लाइड्स तो मैंने खोल ली हैं
Sir, I'm sorry, sir, I couldn't get.
The seizure disorder is often being overestimated by most of the clinicians when we start the patient on enzalutamide, while the trial data really do not show the increased incidence of seizure disorder. The slide which you have also shown.
Yes, sir. No, sir, there is difference. See, it is not significant, but then one needs to mention about that also, sir. When we are saying that more than grade 3 adverse event, so obviously this fall and seizure needs a special mention. Fatigue, see, fatigue, we all know that fatigue is the most common symptom with patient, but then we can't ignore seizures also.
Okay.
So,
चलो मैं ready हूँ.
please. Hello. Hello.
Hello, yes, sir.
So moving forward, any question, any discussion from anyone, our audience participants on this topic?
Sir, I think we can
Okay.
introduce the next speaker.
So moving to our next speaker, Dr. N.K. Warrior. He is no introduction and well-renowned faculty not only in India but also internationally. And he is a senior consultant oncologist and medical director, MVR Cancer Center and Research Institute, Calicut, Kerala, India. And he will enrich our knowledge on the results of phase 3 Aramis trials study. Dr. N.K., please, over to you.
Thank you so much and good evening to all. This is the study which was presented in the last ASCO 2020 virtual meeting. This is actually the final survival results from Spartan study. Spartan study is a phase 3 study of apalutamide versus placebo in patients with a non-metastatic castration-resistant prostate cancer. Apalutamide is nothing but androgen signaling inhibitor, and this was compared to placebo in the subgroup of patients who are having who is at high risk for developing metastasis. So this is the study design. Non-metastatic castration-resistant prostate cancer patients, pelvic nodes less than 2 cm below iliac bifurcation. The PSA doubling time less than 10 months were included, and those who are already on continuous, these patients are already on continuous androgen deprivation therapy. In addition, they have stratified according to the prostate PSA specific doubling time, and more than 6 months versus less than 6 months. And also bone sparing agents used or not, and also lymph node negative as well as N1 lymph nodes were included. And they have stratified into 2:1 stratification and the randomization, and then one arm is apalutamide 240 milligram added to androgen deprivation therapy, and second arm is with the placebo added to androgen deprivation. So the first endpoint was median metastasis-free survival, and then subsequently when patient progresses, the physicians directed therapy of subsequent, and also the sponsor provided abiraterone plus prednisolone. And the final event was analyzed in terms of overall survival events. Here the method and the statistics used were basically overall survival in the first interim analysis was found to be significantly better, and this was, and subsequent events were analyzed according to O'Brien-Fleming type alpha spending function. And this is the final disposition and final analysis. This is how they were planned. And this is the median overall survival, which was significantly higher with apalutamide. About at the median overall survival was 73.9 months with the follow-up of 52 months. And the median treatment duration in the apalutamide was 32.9 months, and whereas the placebo it was 11.5 months, and median overall survival was significantly longer with the ABA arm, as you can see. And also with the unblind, with the primary endpoint in the initial analysis was met, so this was got approved, and then about 19% of the patients from the placebo group was unblinded, and if found to be non-metastatic were allowed to cross over to the study arm. And also you can see there is the final analysis of the overall survival benefit was maintained in across all the subgroup. where you can, this is the forest plot curve where you can see all the subgroups where benefited with the apalutamide compared to the placebo. And this is the subsequent analysis also showed that patients who are on apalutamide had a significantly higher time to start initiation of chemotherapy compared to placebo, as well as there is a significant lengthening of symptomatic progression. So the apalutamide has met almost all the initial endpoints, the time to initiation of chemotherapy, and there is a significant prolongation of symptomatic metastasis, as well as also there is a asymptomatic only marker alone relapses are also prolonged with the apalutamide. You can see about 40.5 months compared to the placebo, where it is just 3.7 months. And one more additional parameter they have studied is the second progression-free survival, which is it's about second progression-free survival is about 55.6 months compared to placebo. It is about 41.2 months. These are some of the adverse events. You can see that grade 3 or 4 events, adverse events are comparatively less, and only one death that due to the myocardial infarction and is thought to be due to apalutamide related. If you look at the various adverse events, you can see the rashes are the majority, and also there are fatigue and hypertension and fall about it's also about 3%, and there is a it's all grade 1 or grade 2 insignificant adverse events in the apalutamide, and the discontinuation rates due to the discontinuation rates due to the side effects were very few and less than 15% of the patients. So the conclusion, the addition of apalutamide to androgen deprivation therapy significantly improves the overall survival and compared to placebo, and with a median overall survival of more than 6 years in the apalutamide arm, and about 14 months improvement over placebo. And it also lengthens time before initiation of cytotoxic chemotherapy in patients with non-metastatic castration-resistant prostate cancer. And also all primary and secondary endpoints were improved with apalutamide. The benefit from apalutamide was observed despite 19% crossover from placebo. Also, the safety profile of apalutamide was consistent with the prior interim analysis, which were again confirmed in the final analysis. So the take-home message is, in the non-metastatic castration-resistant prostate cancer, apalutamide significantly improves overall survival, and this is a practice-changing study. And I hope that in view of the very good favorable safety profile, apalutamide will be a treatment of choice in such patients. Thank you all.
Thank you, Dr. NK, for an excellent analysis of the Spartan study. And really, in the future, I think many more people will opt this drugs with a clear vision after this presentation. Thank you very much. And now I would like to invite our next speaker and my very close friend, Dr. P.S. Dattatreya, for the next presentation. And he is a senior consultant medical oncologist and in Omega Hospital, Hyderabad. And he will be discussing on the phase 3 Aramix study in this prostate cancer. Sir, over to you.
Thank you very much, Sandeep, and a very good evening to all of you. I would like to extend my thanks to the entire organizing team. And after having listened to the previous speakers, I think, as has been rightly mentioned, I'd informed that You can show the slides, and so your team can present the slides. So I'll talk about the Aramis data and the final analysis. And as we know that the Aramis trial is trying to look at darolutamide plus ADT compared to placebo and ADT for non-metastatic CRPC. So similar to the previous two studies which were discussed very eloquently by both the previous two speakers. Next slide. Now the advantage of darolutamide over the previous two molecules, enzalutamide, apalutamide, is it also inhibits the AR like both of them, but it is structurally distinct. And that leads to three important features: low penetration of the blood-brain barrier, favorable safety profile, and low drug interaction potential. I think these 3 points are responsible for us to make us understand that this drug is different than enzalutamide or apalutamide. I mean, for instance, you find apalutamide has patients have falls, rash, and fractures. Enzalutamide patients have falls, dizziness, mental impairment, cognitive impairment, hypertension, fatigue, and severe fatigue. Now, and all of these usually tend to happen because of they being structurally different from darolutamide, and that becomes the advantage of darolutamide. Aramis is a phase 3 trial which looked at the safety and efficacy of adding daro to ADT for non-metastatic CRPC, like Spartan apalutamide or like Prosper enzalutamide. At the primary analysis, the primary endpoint of metastasis-free survival was met with a hazard ratio of 0.41. The median OS was around 41 months with daro versus around 18.5 and placebo, hazard ratio of 0.41, p-value highly significant. Adverse event profile was favorable, and the current presentation of ASCO 2020 looks at the pre-specified final OS and the safety data even after unblinding the primary analysis. So next slide. So we need to realize that this molecule is pharmacological distinct and has active diastereomers which target the wild type AR, and also severe gene mutations, several gene mutations, which can be having resistance to the next generation androgen receptor therapies like enzalutamide or apalutamide. So it's able to target the wild type AR. It's also able to target several genetic mutations which may happen when a patient progresses on enzalutamide or apalutamide. It's able to minimally penetrate the BBB and therefore has less neurocognitive side effects. And a low potential for drug-drug interactions, because usually in patients of prostate cancer or elderly, you find these patients on statins or anticoagulants or antidepressants or calcium channel blockers, and their presence or absence does not make any difference to the usage of darolutamide. I think these 3 points are very, very important and would therefore tilt me in using daro over enza or apalutamide. Now, the Aramis study design was a double-blind randomized phase 3 trial, 1,500 patients randomized 2:1 to daro versus placebo and ADT. Now, the inclusion criteria pretty similar, be it Spartan or the Prosper trial. In September 2018, the primary analysis was done and the primary endpoint was clearly met, 41 months versus 18.5 months. Therefore, unblinding happened, and after unblinding, 170 patients, 1/3 of patients, the placebo arm, went on to receive open-label darolutamide. Now, we are now going to hear very commonly about what is called as hierarchical testing in clinical trials. When the primary endpoint is met, and if the hazard ratio is favorable and statistically significant, only then you will assess the secondary endpoints. And that was what the trial looked at. So once the final and primary endpoint was met, only then you are going to formally assess the secondary endpoints. And what were the secondary endpoints tested hierarchically? OS, time to pain progression, time to first cytotoxic chemotherapy, and time to the first symptomatic skeletal event. So these are the secondary endpoints we are going to discuss today, which were tested hierarchically. So therefore, I think we need to understand that many of the ongoing trials talk about hierarchical testing. Therefore, we need to get familiar with this. So coming to the OS data, the first secondary endpoint, 6% advantage, absolute numbers, 77 versus 83% at 36 months, favoring darolutamide, or placebo hazard ratio of 0.69, p-value highly significant. Now, mind you, again, I told you, 1/3 of patients, 171 placebo arm, went on to get darolutamide when progression happened, when the primary endpoint of blinding was done, because the primary endpoint was blood. So unblinding happened. A good significant patients on the placebo arm went on to get daro, and still you find an improvement in the OS. I think that's very, very important with this molecule, that despite unblinding happening and 170 patients going on, the placebo arm getting daro, you still find an advantage in OS. The other secondary endpoints, next slide, please, looks at time to pain progression, time to first cytotoxic chemotherapy, and time to the first symptomatic skeletal event. And all of them uniformly favor the usage of darolutamide over placebo. So androgen deprivation therapy plus darolutamide was able to meet all the primary and the secondary endpoints, despite on the placebo arm, 1/3 of patients receiving daro, and despite hierarchical testing in this particular clinical trial. So then we are worried about the adverse event profile. And as I told you before, this molecule has several advantages because it is structurally distinct than apalutamide or enzalutamide. So coming to the adverse event profile, next slide. And as you can see, across all grade adverse events, all of them seem to be less than 10%. In fact, then 3%, 4%, 5%, 7%. Now, fatigue comes at 13.2%, but grade 3-4 is around 8.3%. So, final safety analysis hugely favors the use of darolutamide, and more than 90% of patients possibly will not have any troublesome side effect. 13% of patients may have some fatigue, but 8% of them only would have grade 3 or grade 4. Next slide. So let's try to compare with AR antagonists. Next slide. So coming to Spartan, where we had apalutamide, on Enza, where we had the Prosper trial, the enzalutamide. Now these are indirect comparisons, so we'll have to wait for data of 2 more trials which are comparing daro to enzalutamide. But in the meantime, we can do some comparison indirect, and you actually find no statistically significant differences. But having said that, when you look at absolute numbers, patients on apalutamide would have more falls, more rash, more fractures. Enzalutamide, more falls, more dizziness, more cognitive impairment, more hypertension, more fatigue or severe fatigue. And that's why in absolute numbers, daro seems to be better than APA or enzalutamide. Next slide. So to come to the conclusion part, in the phase 3 RMS trial, daro plus ADT reduced the risk of death by 31%, despite a significant proportion of patients in placebo arm receiving subsequent life-prolonging treatment, including darolutamide. The 3-year OS, 6% advantage absolute numbers, hazard ratio 0.69. Additional benefit happened in all secondary endpoints, including time to pain progression, or first cytotoxic chemo, or the first symptomatic skeletal event. No new safety concerns identified in the primary and the final analysis. All adverse events are basically class-wide safety profile, but the advantage seems to be of using daro, because in absolute numbers, the adverse events seem to be very few. And so we have many similarities among the Spartan, Prosper, and RMS as far as the enrollment of patients is concerned and the inclusion criteria. All 3 drugs also improved the key secondary efficacy endpoints, and therefore the primary differences lie in the safety profile of these molecules. And that's where I believe Daro has an edge over apalutamide or enzalutamide, including the fact that it seems to be having less penetration into the brain. It also seems to be having a very less incidence of adverse cardiovascular events, and more than that, very low potential for drug-drug interactions. So I would like to give, if I have to choose, I would tilt towards darolutamide because of its favorable adverse event profile. Otherwise, efficacy-wise against the prostate cancer, all three are equal from my side. Thank you so much.
Thank you, sir. Really doing a nice justice to this trial and making the crystal clear presentation and concept to us, presented to us, so that we can use now what we want to use. And really, I salute and respect your ability for show stealer like this, and always making us a more wiser in each and every topic whenever we have heard you. Thank you, sir. Thank you for your nice presentation.
Thank you very much. Thanks, everybody.
Now, I think Dr. Rajiv Suri is ready for their presentation. And I would like to invite Dr. Rajiv Suri for the next presentation. And Dr. Rajiv Suri is a senior consultant, ABBIMS, and Dr. RMN Hospital, Delhi. And is also president, Genitourinary Cancer Society of India. Sir, over to you.
Thank you very much. Sorry for the interruption. I am in a remote Himachal village right now, and there was a problem. Can you see my screen now?
Yes, sir, we are able to see your screen.
Okay, so I'm presenting 2020 results of the music study. That is the Michigan Urological Study Improvement Collaborative Registry. This is an important study as urologist. This plays the role of surgery in the spectrum or multimodality treatment of high-risk prostate cancer, very high-risk prostate cancer, and metastatic. All the data is mostly from West. Very few small series has been done from Bangalore and other places, but we have mostly retrospective, observational, randomized controls trials are not there, and therefore the factors which are governing the choice today, which therapy you have to go, is the ease of therapy, disease recurrence patterns, and salvage options, long-term complications, and cancer-specific survival and overall survival. And in the local advanced prostate cancer, which is a category of high risk, very high risk, and in that also the reviewed literature, this is the paper which was published in 2014. It was concluded that the best indication for initial radical prostatectomy when there is locally advanced high risk. Now where we stand today, the radical prostatectomy gives us a cure rate also, and as monotherapy, and also as part of the multimodal therapy, where we add the ADT and radiotherapy. And 30% of the patients present with the locally advanced prostate cancer in our practice, and Indian men have higher PSA to disease ratio. Uniformity in pathological interpretation of the biopsy is not there, and that is very important in the fresh understanding that the Gleason, according to Gleason grading, we have changed the severity, the risk category also. 10 years back, our understanding was different. And if on operation we were finding lymph node positive, enlarged in the pelvic lymph nodes, and then we were abandoning the surgery, the radical prostatectomy, and we were advising hormone therapy. But that is not now. It is now we are doing the radical prostatectomy and extended pelvic lymph node dissection. And therefore, the role of as monotherapy or as the combination therapy has come into the practice, and EAU guidelines 2015 onwards till today in 2020 is giving the place as the A grade recommendation according to the level of evidence from 2A to 3 of different advancements or the risk categories for the radical prostatectomy. What is the advantage in high risk or locally advanced prostate cancer? It removes the confounding of over staging and overgrading. Monotherapy can offer cure up to 44 to 46% and can categorize patient to receive radiotherapy and androgen deprivation therapy. It enhances the cancer specific survival also. So to conclude, as monotherapy or as combination therapy, it is important, and in European Association of Urologist guidelines, EAU guidelines, the 2020, which are followed by Urological Society of India, radical prostatectomy has the strength of as a strong recommendation for a radical prostatectomy in highly selected patients, and also along with extended pelvic lymph node dissection. We can add to the radiotherapy and ADT. NCCN guidelines also reflect the same views. And mighty men diagnosed with metastatic prostate cancer, where earlier the surgery was out of question, local consolidative surgery or therapy we are adding, and that is giving better results, and 5-year overall survivors are better in the localized tumor, and also they are good in the locally advanced and metastatic cancer where oligometastasis is there, especially. In this study, which we are discussing today, Michigan Urological Surgery Improvement Collaborative, which is music study results, the guideline recommended management of these categories of high risk is discussed, and increasingly patients with regional or distant metastasis are being subjected to definitive local therapy with surgery. And this study retrospectively investigated. The study population was from 2012 to 2018, and 9,208 patients were there, and 2023 patients, that is 22%, were classified as having high risk prostate cancer or locally advanced or early metastatic. The risk group stratification was done according to the stage, according to the grade, Gleason 4 or 5, and they are very high risk if it was the pattern, primary pattern was 5, and metastatic prostate cancer where clinical N1 or M1 disease. Outcomes were evaluated. For primary outcomes were according to the biochemical recurrence, where the PSA after surgery was more than 0.2, and also secondary outcomes were there when presence or absence of extraprostatic extension, EP, seminal vesicle invasion, or positive lymph node and positive surgical margins were there, and perioperative events were there. So the statistical analysis was done pre-treatment, and on oncological outcomes of high risk, very high risk and metastatic groups was compared. Kaplan-Meier analysis of biochemical recurrence and multivariate analysis were performed with significant setup of probability less than 0.05. There were 844 patients in high risk, 1,052 in very high risk, and N1, M1, that is the metastatic, in 190. And PLND was performed in more than 95% in all the categories. That is a uniform practice. And results were that primary outcome of 3-year biochemical recurrence-free probability was very good. 2/3 of the patients with 6% of hazard ratio, and 49% and 47% respectively in very high risk and N1 and M1 disease. And the PSA, if it was 10 to 20, the hazard ratio was 2.07, and it was increasing as the PSA level was increasing. And according to the risk group, very high risk and metastatic, the hazard ratio was 1.45 and 1.63. And the Gleason grading 3 to 5, and also the clinical stage of T2 to T4 and African American race were also significant biochemical recurrence predictors in the multivariate study. So conclude, nearly 25% of the radical prostatectomy were performed for high risk or higher prostate cancer. Although these patients are clearly at higher risk for biochemical recurrence, and many receive additional treatments as a multimodal therapy, the majority are disease-free according to music study results after 3 years of surgery, and radical prostatectomy therefore appears, as was also contemplated for last 5 years in various studies and publications, appears to be an oncologically sound approach for patients with the high risk and very high risk, and patients with suspicion of N1, M1 disease that undergo radical prostatectomy appear to have similar oncological outcomes. The value of the local treatment in the setting of confirmed metastatic disease is the focus of ongoing clinical trials and is the best performed in this setting. And after evaluating and after also studying the concerns and limitations, the surgical modality is promising, which is also presented from this results of music registry. Thank you.
Thank you, Seth, for a nice presentation on radical prostatectomy, and also enriching us with the new, this all kind of treatment, like we have discussed radiotherapy, we have discussed other treatment, and now we are also now more wiser in seeing this your presentation for the prostatectomy and surgical part. And thank you very much, sir. And now I would like to invite our next speaker, Dr. Vivek Agarwal from Vivek Agarwal. He is a senior specialist, Department of Medical Oncology and Hematology, Narayana Super Specialty Hospital, Calcutta, and he's going to present a meta-analysis studies on the docetaxel treatment. Over to you, Dr. Vivek.
Yeah, thank you, sir, for the kind introduction, and I thank the organizers for giving me this opportunity, especially Dr. Tarachand and Dr. Rushabh and Dr. Rajit. Thank you for having me here. So today I am given the task of presenting this abstract, which was presented in the recent ASCO, adjuvant docetaxel after definitive radiotherapy for high-risk prostate cancer, a meta-analysis of the randomized clinical trials. These were the 3 investigators from Colombia. So locally advanced or high-risk localized prostate cancer has a relatively poor prognosis. The standard management usually uses radiotherapy for these cancers with the support of long-term hormonal treatment. And improvements in local and systemic therapy are likely to be beneficial. We all know that in the metastatic hormone sensitive setting, in the prostate cancer, docetaxel has changed the practice, and we have achieved really good outcomes by introducing docetaxel early. So likewise, it goes that probably in these high risk non-metastatic prostate cancer also, we have to improve the outcomes, and probably adding docetaxel early in the adjuvant setting after radical radiotherapy might be a good idea. There have been a few clinical trials that have addressed this issue, but the results have been inconsistent. So this meta-analysis was done. It was including all randomized phase 3 trials, which has tested the efficacy of docetaxel after radiotherapy in high risk prostate cancer. A systematic review of different databases was conducted, and 3 investigators independently selected all the articles and verified the inclusion criteria. 382 publications and Four phase 3 randomized controlled trials were selected. That is the Stampede, RTOG 521, SPCG 13, and JETAG 12, fulfilling the inclusion criteria. OS and DFS between the intervention group, that is adjuvant chemotherapy with docetaxel, and the control group, that is without adjuvant chemotherapy and only ADT, was compared by using the hazard ratio with 95% confidence intervals, and the pooled effects were calculated using the random effects or fixed effects model based on the heterogeneity of the including studies, so that they would clear any sort of bias that is there. Now, before we go on to the results, let us look at these studies. So in all these studies, the high risk was based on Gleason score, T stage, or the PSA levels. The GETAC 12 had 413 patients, and it gave treatment with 4 cycles of docetaxel estramustin. The primary endpoint was RFS, and yes, the RFS was improved, and in a follow-up they showed that the clinical RFS or metastasis free survival is also better. In the RTOG 521, probably this is the best evidence that we have got for adjuvant docetaxel post RT. So it was a large trial of 600 patients, and they gave 6 cycles of docetaxel. The primary endpoint was overall survival, and yes, there was some improvement in the overall survival with a hazard of 0.7, and it was the 4-year OS was improved from 89% to 93%, although the two-sided p-value was just below significance. In the SPCG 13, it had 376 patients, and yes, they also used 6 cycles of docetaxel, but the primary endpoint was again biochemical disease-free survival, and this trial did not show any improvement in the biochemical disease-free survival. The Stampede study basically had patients mostly of metastatic hormone sensitive prostate cancer, but they had a handful of patients where they were localized high risk patients, around 200 patients, and again 6 cycles docetaxel was used, and they had a separate analysis for these patients with the endpoint of RFS, which was shown to be improved. But this was not a pre-planned analysis. Again, when we look at the high risk criteria that was selected for all these studies, so GETAG trial took high risk patients as one or more of either Gleason's more than equal to 8, PSA more than equal to 20, either T3 or T4, or node positive. The SPCG included both intermediate as well as high risk. So they had patients with T2 with Gleason's of 7 and PSA greater than 10, or a T2 with GS 8 to 10 with a PSA less than 70, or any T3. Whereas the RTOG 521, they had defined high risk as either with Gleason's 9 to 10 with any PSA less than 150 and any T stage, Gleason's 8 with PSA less than 20 and T stage either greater than equal to T2, Gleason's 8 PSA 20 to 50 with any T stage, or Gleason's 7 with PSA 20 to 150 and any T stage. So what we see is that there is a lot of heterogeneity so far as the high risk selection is concerned, as well as the primary endpoint of all these studies is concerned. And there was also some heterogeneity regarding the number of cycles and the drugs used. When you look at this meta-analysis, though there were 2,034 patients who were eligible for analysis, 899 in the adjuvant docetaxel arm, and 1,135 in the ADT alone. And the results showed that there was an OS benefit with docetaxel with a hazard of 0.72. And there was also a DFS benefit with docetaxel with a hazard of 0.74. Heterogeneity was not found between the included studies for overall survival, but it was found between the studies for disease-free survival, and there was no publication bias as per the investigators. So they concluded that this meta-analysis shows that docetaxel after definitive radiotherapy in high-risk prostate cancer is likely to be more effective than standard of care in terms of overall survival and disease-free survival. Now, when we look at this abstract critically, well, we have to understand that this is just an abstract. The full paper is not there, and hence we cannot comment on the subgroup analysis as well as the toxicities that were faced. And the data somewhat looks convincing when we look at all these trials, but patient selection is probably the key, and the high risk individuals are the only ones which are going to benefit. Mind you, in RTOG, there was only a 4% overall survival benefit with a short follow-up of around 4 years. So if you look at the guidelines still don't universally recommend it. What they say is probably for the selected fit young patients with high risk disease. And we need more long-term follow-up data and further prospective studies. And one of the questions that again remains unresolved, as we are seeing most of the agents are coming earlier into the disease, probably we are also going to see some abiraterone and enzalutamide also in this setting. So this is the latest ESMO June 2020 prostate cancer guidelines, and this is what they state, that in men with high risk localized prostate cancer, very long-term follow-up is needed to show survival differences. And assuming that the cooperative groups are able to collect long-term data, this should be achieved around 2020 to 2025, somewhere in the middle. And based on the available data, offering docetaxel based therapy may be a reasonable option for the younger fit men with multiple risk factors for recurrence. Hereby I conclude. Thank you. And I also invite you to our Asian Cardio-Oncology Conference series, which is being held every Thursday till 5th of November, starting 7 p.m. Thank you.
Thank you, Dr. Vivek, for a nice and excellent presentation. And now, on the behalf of organizing committee and team and myself, I thanks to all eminent and prominent speakers who have participated in this focused prostate concern. And really, we have taken a lot of home message from this all conversation and discussion. And tomorrow morning is also working day for us. And from tomorrow morning, we will think little bit different to treat, how to treat this prostate cancer and how to treat in different stages of the cancer. And really, I am very thankful to all my eminent speakers and my presenters who have joined us with this. And now with this, I hand over my further proceeding to our organizing committee. Thank you very much for giving me an opportunity for this nice discussion.
Thank you, Jasuja sir, for covering for 3 chairpersons. I will invite Dr. Senthil Rajappa, Senior Medical Oncologist, Indo-American Hospital, Hyderabad, for next moderation. And I will also invite the panelist, Dr. Himang Bakshi, Senior Uro-Oncologist, HCG, Ahmedabad, Dr. Kushal Gupta, Medical Oncologist, Manipal Hospital, Bangalore, Dr. Bhavesh Parekh, Senior Medical Oncologist, Shelby Group of Hospital, Ahmedabad, Dr. Sangeeta Parithan, Consultant Medical Oncologist, ESIC Hospital, Bangalore, Dr. Ruchir Bhandari, Radiation Oncologist from Apex Hospital, Jaipur, Dr. Deepak Shukla, Consultant Medical Oncologist from Manipal Hospital, Jaipur, Dr. Anshuman Kumar, Director Surgical Oncologist from Dharamshila Narayan Multi-Speciality Hospital, New Delhi.
All right, thank you so much, organizers, for asking me to do this panel discussion. We are half an hour behind time, so I'll try to save some time for the organizers and hand it over back a little early. So I'm starting with this risk stratification that is put up here on your screen. So high risk, can you hear me?
Yes. Yes, sir, we can hear you, sir.
Very good, very good, very good. All right. So this is high risk prostate cancer, and then you've got locally advanced prostate cancer. This is the EAU risk factor, because many of us medical oncologists are not very aware of this stratification, and hence I thought I'll start with this stratification before I go on to this case. We've got a fit 65-year-old with the lower urinary tract symptoms of 6 months, no comorbidities. Rectal examination showed a hard nodule involving both lobes. The PSA was 28, which means you straight away go into a high risk. Biopsy course 5 on the left and 3 on the right show adenocarcinoma, acinar adenocarcinoma, Gleason group 5. An MRI was done showing involvement of both lobes, query, seminal vesicle involvement, no lymph nodes on the MRI. The PSMA PET showed findings similar to the MRI. There were 2 pelvic lymph nodes. The largest is 1.2 centimeter, as usual, a query metastasis. So this is high-risk prostate cancer. T2C, query 3 because there's a doubtful seminal vesicle involvement. NX, as I have put up there, because we are not too sure of that. You might call it very high risk also by some classifications, but at least let's, for this discussion, call it high risk prostate cancer. So the burning question, I didn't want to go and discuss each of these abstracts because many of them are biased retrospective analysis. So I thought I will discuss a case and show you the guidelines. So let's start with the urologist, Dr. Hemang Bakshi. Are you ready to take this patient for radical prostatectomy with extended lymph node dissection? Dr. Bakshi.
Yes. So considering the fact that he is a 65-year-old fit man, I would offer him both options. One is RP plus ELND and second is RT plus ADT. Now the guidelines, level 1 evidence, I know favors RT plus ADT, but RP plus ELND has the advantage of accurate pathological staging and giving you an exact pathology and a biomarker subsequently for follow-up, as well as taking care of the urinary symptoms. So I would offer that option, yes.
So how does the pathological characters help you? Do you say that it's for prognosis or is it for treatment decision? How does that help, Dr. Bakshi?
So yes, both ways. So if you get, say for example, final pathology shows T3B and the nodes which you have shown are a doubtful PSMA uptake, suppose they turn out to be negative, which they sometimes do in around 20% or 30%, you would find that the nodes were inflammatory in nature. So if it is T3B and 0 and the margins are clear, I might not add any further therapy at that point of time. So I would wait till the PSA is rising and go for salvage radiation. So I would counsel the patient that he is not going to be cured by a single modality. But having upfront surgery helps in a way of removing his symptoms, doing an accurate staging, and knowing exactly when and where the further therapy should be given. That's my
Great. So you're saying that your pathological staging will be good. You will be able to prognosticate better. You've got tissue for molecular analysis if the medical oncologist wants it later. And you may avoid giving this patient androgen deprivation therapy if you find that the lymph nodes are negative. Is that right? So that's the short summary of what you said. Dr. Ruchir, what is your counter to Dr. Hemang Bakshi?
Yeah, I would differ a little.
You have to differ, Dr. Ruchir.
Yeah.
You better not say yes for
right.
surgery.
Yeah. So I would go by the guidelines. I would offer this gentleman 6 months of neoadjuvant hormone followed by radiotherapy and adjuvant hormone therapy for 2 years.
Why would you want to do that? I want you to counter Dr. Hemang.
Yeah,
I'll show you the guidelines later.
Yeah, there are certain things. One, that the PSA is quite high. Two, the stage is high. The lymph nodes are positive on PSMA PET. And I mean, there are all high-risk features in this patient. And by all probability, this patient would go for adjuvant radiotherapy, even if he is offered surgery in the upfront.
So your point is that you may end up doing too many of these therapies on your patient and adding to the morbidity. Is that correct? So Dr. Hemang Bakshi, let me come back to you. Let me ask our medical oncology friends to be the judges here. Dr. Bhavesh, who is more convincing, Dr. Hemang or Dr. Ruchir?
I am absolutely convinced with Dr. Hemang Bakshi.
Because he's from Ahmedabad, is it?
No. Because because today you are wearing a blue dress, so you are true Indian.
Oh my goodness! Thank you. I didn't realize that. All right, Bhavesh, go ahead.
So the point here is that again, as Ruchir Bandari tells that. So the point here is the selected patient. So high risk, the selected patient. So that's what I feel that MRI pelvis or PSMA scan can tell the experienced surgeon that whether I am doing a one modality, and especially you had written the word extended pelvic lymph node dissection. So very few neurosurgeons are also doing this lymph node dissection. So I think the radical prostatectomy with extended lymph node dissection, and once post-operative if the PSA is rising, or we can have an option of adjuvant. We had so many trials also, as well as adjuvant
Dr.
ADT.
Bhavesh, we keep it short because we are running short of time. So you are in favor of Dr. Hemang Bakshi, is that correct?
Perfect.
Great.
Perfect.
Very good. Dr. Anshuman, you are the surgical oncologist on the panel. What would you say? Dr. Ruchir or Dr. Hemang? Dr. Anshuman, are you there? Organizers, is Dr. Anshuman there or he's not?
Sir, Dr. Anshuman is not there.
Dr. Anshuman is not there. It doesn't matter. Is Dr. Gagan or Dr. Rahul Krishnatre still around, or they have left? All right, never mind, never mind. So, so this is the latest EAU guidelines of the European Urology Association. As Dr. Bakshi said, offer radical prostatectomy to selected patients. And as Ruchi rightly pointed out, that these selected patients ideally should be patients who are less likely to need radiotherapy as an adjuvant after radical prostatectomy, because you don't want to do too many therapies because you're adding too many complications there. So if you have a patient where the likelihood of needing adjuvant radiotherapy is less, now who's that patient who's likely to need more radiotherapy? As Ruchir rightly pointed out, it's that patient with many high-risk factors, right? If you've got a Gleason grade, Gleason group, that's 5. If you've got a PSA, that's 65. And you've got doubtful seminal vesicle involvement and so on and so forth. This patient has got a great likelihood of needing radiotherapy you may want to avoid. But on the other hand, if the likelihood of needing radiotherapy is less, then you would be tempted to do radical prostatectomy, because the advantage, as was rightly pointed out there, is getting tissue or prognosticating better, and very importantly, avoiding the need for adjuvant androgen deprivation therapy, the complications of which cannot be understated at all. So let me come back to Dr. Bakshi. Dr. Bakshi, let's say if this patient had a clinical node that was positive, and we said that MRI showed a lymph node in the pelvis that's suggestive of metastasis, would you still want to do? Because the guideline still says you can do it in highly selected patients. So clinical lymph node positivity, what would you do?
So CN1, according to NCCN, would fall into regional disease, and the guidelines clearly say that radiation is the primary treatment of choice. Now, if it was a single node, I would look at the size and the dimension, the short axis diameter, etc. If it is confirmed positive, more than one, then I would not operate. If it is one, well, I'll discuss it with the patient, but I would go more in favor of radiation for clinical node positive disease, especially if there is more than one.
Absolutely. Very perfectly answered, Dr. Bakshi. I'm so happy that you're not biased towards doing surgery. I think you gave the most appropriate, at least I'm happy with your answer.
Thank you. That means a lot.
Dr. Ruchir, so you sure would agree with Dr. Hemang there? Definitely. So you would take this patient up for radiotherapy. So I think our panelists have, given us the most appropriate answer based on the guidelines. So I'll reiterate that point again, that always, if you do radiotherapy for high risk or locally advanced or loco-regional disease, you will end up needing to do androgen deprivation therapy. But you may be able to avoid that if you did surgery. But here is a case where the likelihood of ADT is high, the likelihood of needing radiotherapy is high. So as was rightly pointed out by Dr. Bakshi, it will be better to subject this patient to radiotherapy plus ADT if that lymph node was positive. Dr. Ruchir, what type of radiotherapy? We heard the CHIP study being discussed. Would you do 60 gray or 74 gray? What is your rule of thumb now?
So yes, after the CHIP trial results were out in 2016, there has been a lot of interest in moderate hypofractionation, and many centers are doing 60 grays in 20 fractions now. I usually prefer 74 grays in 37 fraction because when you hypofractionate the patient, you need to be very sure of what you are treating. You need daily image guidance, you need a strong and a strict bladder protocol, a strict rectal protocol, and a very compliant patient. So if you're happy, yes, if all these factors can be taken into consideration, go for moderate hypofractionation, 60 gray 20 fractions. Else, go by the gold standard treatment, 74 grays and 37 fractions.
Great. So depending on the patient compliance and the
and image guidance, you need a very good image guidance.
But I think yours is a high-tech field now. So I think we are so much dependent upon image guidance for planning and so on and so forth. I very much agree that this patient should go. I mean, that's the kind of radiotherapy that you would want to do. Okay, so our patient went in to have surgery. So this is the pathological staging. That's T3B, N1, and obviously MX. 3 lymph nodes show tumor deposits. 4 show reactive changes. Perineural invasion is seen. Lymphovascular emboli occasionally seen. So the ink margins are technically free of tumor. So it's a T3B-N1. And Dr. Bakshi, after his surgery, sends it to Dr. Kushal to decide on what is to be done next. Dr. Kushal, which would you choose among this? And this patient, 6 weeks after surgery, is found to have a PSA that's 0.02, which is very much acceptable after good surgery. So what would you do, Kushal?
Sir, I would go for option 2, adjuvant ADT for 2 to 3 years. So I would avoid any adjuvant RT as of now because all the margins are negative. And there is really no reason why RT we should be, we should be employing RT at this point of time.
Very good. ADT for 2 to 3 years. Okay. Deepak, would you want to do radiotherapy along with ADT or you would not?
Sir, I'll agree. Even in this case, adjuvant androgen deprivation alone is an option, but again, considering node positivity, radiotherapy along with capsular invasion is also an option. But adjuvant androgen deprivation, and when there is a PSA failure, then salvage RT can be used in this patient.
Very good. You raised a very important point, Deepak, that salvage radiotherapy can be used. So all of us seem to be agreeing on ADT. We'll come back to radiotherapy. What about adjuvant docetaxel, Bhavesh? So we have agreed upon ADT. We have a little bit of a trouble with doing radiotherapy. What about docetaxel?
Vivek Agarwal also mentioned a very good result. I personally feel we had also worked with Hemang Bakshi, and sometimes even in some of the selected case, we had also given neoadjuvant docetaxel also. So in this particular case, because he's a 65-year and fit patient, I still feel that patient lymph node positive will definitely benefit with adjuvant docetaxel plus ADT.
So adjuvant docetaxel plus ADT. We'll come to Dr. Hemang last. I will give him the last say on what should be done to this patient. Ruchir, nobody wants radiotherapy. Ruchir, you have to, say that you have a place in this patient. 3 lymph nodes that are positive.
I will go with the house. Radiotherapy is not required in this case. Radiotherapy, the only indication of adjuvant radiotherapy now is if after 6 weeks, the PSA is more than 0.1 nanogram per ml, irrespective of the margin status. Because adjuvant radiotherapy.
You muted yourself, Ruchir.
Sorry.
Yeah, great. We can hear you. Go ahead.
So radiotherapy is needed if after 6 weeks PSA is more than 0.1 nanogram per ml, irrespective of the margin status, and because radiotherapy is only going to offer this gentleman disease-free survival benefit and no overall survival benefit.
How many positive nodes would you want to have to do radiotherapy?
No, there is no such indications.
There is no such indication. Dr. Bakshi, I'm asking you for your final say on whether this patient should have radiotherapy or not.
So he's considering that his PSA is 0.02. I would wait for salvage radiation rather than giving adjuvant. And regarding ADT, the guidelines I know would mention that more than 2 lymph nodes positive, you need some kind of adjuvant therapy, radiation or plus minus hormones. But having said that, the PSA is too low right now for me to just jump into any kind of therapy. If at all radiation is required, I would combine it with ADT later on as a salvage.
Great. So I think all our panelists seem to be agreeing on the fact that we wouldn't do radiotherapy immediately. We will wait for this patient to fail, if at all, before we start radiotherapy. As the number of lymph nodes increases, there seems to be a greater reason to do radiotherapy in our patients after surgery. But here is a patient who's got only 3 lymph nodes. there's a good reason to wait and watch rather than go ahead and do adjuvant radiotherapy right now. So we moved away from the paradigm of doing adjuvant radiotherapy for all patients who have high risk after surgery to doing it only selectively in patients who have got a great chance of failing, a very high chance of failing. So that's a very, very important point. I'm not too sure I would agree with Bhavesh that docetaxel also should be used, maybe for a patient who's got many, many more risk factors on a case-by-case basis, because we seem to be moving into a paradigm like breast cancer, where you want to have surgery, you want to have radiotherapy, you want to then have hormonal therapy, and then you want to have chemotherapy. I think that's where we seem to be trying to push this, but I think it's
this particular case, Senthil, even the LVI is also present and occasional
perineural invasions
yeah,
also,
yeah.
yes. So you have your point, Bhavesh. I'm not saying that it's absolutely wrong, but my opinion would be that we would just do ADT, wait to see if this patient will fail, then add radiotherapy and so on and so forth. Okay, so the inevitable thing happened. This patient was administered radiotherapy and ADT. 12 months on ADT, the PSA starts to increase. Dr. Bakshi, what would you do in this situation?
So his PSA is now 2.1, right?
Yes, yes.
Over 4 months. And in 12 months, so his doubling time would be around...
Okay, let's take that the doubling time is 3 months, just for example.
Okay, so then first thing at 2, I would do a PSMA PET.
Very good.
To find out where the disease is, and based on that, I would like to treat.
Very good. Right. So let's ask Ruchir. Ruchir, you have not radiated. The patient is sent to you now. What imaging would you do? Would you want to do an MRI and a bone scan, or would you want to do a PSMA PET?
I would say, depending on the availability, a CT thorax, abdomen, pelvis, and a bone scan. Or if you have a PSMA PET facility, I would go with that.
Which one would you prefer?
I would prefer CT thorax, abdomen, pelvis, and bone scan.
Why is it that you prefer a CT thorax, abdomen, and a bone scan? Ruchir?
Well, Ruchir, I mean, yeah. Hello?
Yeah, I can hear you, Ruchir. Please go ahead. Why do you prefer, a CT thorax, neck, chest, abdomen instead of a PSMA PET scan?
I think it's been used for a very long time, and I'm quite confident with this the results of that.
So you are quite confident with the results of that. What about Deepak and Kushal?
Sir, I'll prefer PSMA PET CT, but I'll agree with Dr. Rocher that the previous guidelines that we are following, the trials only included CECT, thorax, abdomen, and bone scan for selecting these patients. So PSMA PET CT would overdiagnose metastatic disease. Some of these patients were included in trials giving local treatment. So
Kushal, do you agree with?
Sir, I agree with Dr. Hemang sir and Dr. Ruchir. So PSMA PET, I would prefer PSMA PET, but although I agree that CTs can also be employed.
Okay, so everybody seems to be preferring a PSMA PET, though they are okay to do a CT neck, chest, abdomen. Because if you do a CT neck, chest, abdomen, there's a greater chance that you will get into this situation of being a candidate for one of the SPAR trials. SPAR stands for Spartan, Prosper, and Aramis. That's how they are very famously called now as the SPAR studies, where you were randomized to placebo or one of those antigen targeting agents. But I think this is a very, very interesting statistic here that I put up. And this was a question that was typed more than a couple of times on the chat box. They looked at 200 patients, retrospectives, who had PSMA PET and the conventional imaging. And you'll be surprised to know that only 2% of patients did not have a detectable lesion either in the pelvis or elsewhere when you did a PSMA PET. So I think we slowly will move to the PSMA PET era, though we are in transition now. And very soon, for better staging and better decision making, it would be better to have a PSMA PET rather than a CT neck, chest, abdomen, because the likelihood of picking up more disease is there and your treatment would be much more appropriate. So Bhavesh, PET CT or CT neck, chest, abdomen?
PSMA PET CT.
PSMA PET. Okay, let's say the PSMA PET did not pick up anything at all. What would you do next? PSA started rising and the testosterone is in castrate levels.
So the most important part here is to decide the further treatment is the PSA doubling time. So as you rightly told, it is a 3 month. So I think with this, whatever the recent data or whatever the we had like as you Prosper, Aramis and Spartan trial, definitely is a new drug. There is a scope of that new drug. But till that, or if median OS is not reached, I think we have to go for depend on the metastatic, because again here we had no biochemical rise, but whether patient is symptomatic or asymptomatic, that is also one of the point to be considered.
But these past studies did not look at symptoms, Bhavesh. They just looked at rise in PSA and PSA doubling time of less than 10 months. And you just had to do an imaging and you found there was no disease. They were randomized to either placebo or one of these. Because once you start having symptoms or you're picking up, then you're going to the next generation of trials with abiraterone or enzalutamide or, one of those
Correct.
studies. Right?
Correct.
So these were patients who did not have any detectable metastasis. Dr. Bakshi, being the senior most of all of us, do you think the SPA studies need to be redone with PSMA PET, or do you think we have to move on and you don't want to ask for evidence again?
Well, there will be the Will Rogers phenomenon in play if we employ PSMA PET in every study. As you rightly pointed out, 98% will fall into the metastatic category. But coming back to the question of whether we should treat this patient, if you ask me, I would give the patient two options based on this evidence. We would have enzalutamide, the easy availability as compared to the other two, versus doing nothing and observation. Although the PSA doubling time less than 3 months is suggestive that we should be doing something, and the best drug would be enzalutamide right now in clinical practice.
Right. So I think the important carry home from these past studies is that in the PSMA PET era, you are very, very unlikely to find a patient who will fit into the inclusion-exclusion criteria of the past studies. But if you find one like that, and as Dr. Bakshi rightly said, if you have a patient whose prognosis is likely to be poor based on rapid PSA doubling times, then it might be worthwhile considering one of these options that is put up here so that now this is clearly shown to be improving overall survival. So for me, the SPA studies reiterate a very, very important point that early treatment improves overall survival in patients with prostate cancer. But in terms of its clinical utility, I think it's very, very limited. We just got 2 minutes to go. Bhavesh, which of the three drugs, Bhavesh, Satya beautifully sold darolutamide to us. So would you buy it? Or would you say, no, I am all right with enzalutamide or the other one, apalutamide?
No, I will go with Satya, or I will go with durolutamide.
So Satya did his DM at GCRI. So again, you are siding with Satya, it looks like.
No.
You're not?
you are trying to bias me, but I will not go for bias. I will go for the science.
Very good. Excellent, Bhavesh. Kushal and Deepak, what would you choose of the three?
Sir, I only have an experience with enzalutamide, so
very good.
Very good.
Right. All right.
Well, sir, Daro has a better toxicity profile, but again, it has to be taken twice daily. So, considering the toxicity profile, Daro is better.
Very good. I very much agree with what Satya said, that with the available data, the toxicity profile tilts the balance in favor of darolutamide rather than the other drugs. So I will, are there any other points that any of the panelists want to make before I summarize and hand it over back to the organizers? Anybody?
Can I just make one point?
Yes, sir, please.
Just 1 minute. So what clinically, what you have outlined the case is not very common. It does come into clinical practice, but what we see as uro-oncologists is an artificial non-metastatic CRPC or non-metastatic CRPC case when an orchidectomy has been done for a localized disease wrongly a few years back, and the patient comes with local disease. Now that is not mentioned in any guideline. What should we be doing? Should we be doing local therapy? Suppose the patient comes with an orchidectomy done 5 years back when the disease was localized to begin with, and comes 5 years later with a disease which is still localized to the prostate, whether we should be doing radiation, whether we should be doing surgery. These kinds of cases we see more often than the ones...
I very much agree with you, Dr. Bakshi, that Yes, these are odd cases that keep cropping up now and then. I don't think we have high levels of evidence to really say what is to be done in a situation like this. But I think we will end up using our judgment and some extrapolation in a situation like this rather than really going based on scientific evidence. So let me summarize, we are running out of time. Radiotherapy and radical prostatectomy with an external lymph node dissection are options for high risk and locally advanced prostate cancer. As we said earlier, we need to individualize patient selection depending on the need for adjuvant radiotherapy, ADT, who's ready for what, operability, and so on and so forth. Bulk of the prostate, low urinary tract symptoms, all of these need to be considered. Radiotherapy is always followed by ADT as adjuvant in this category. 2 to 3 years is what we would recommend. And ADT and radiotherapy are to be used selectively after radical prostatectomy. I am still not convinced that docetaxel should be part of this group of adjuvant therapies, but I'm really not against somebody based on the available evidence and a very high risk features that you want to use docetaxel, it's fine. As far as the SPA studies are concerned, as we discussed, the applicability is very limited as far as clinical practice is concerned. The risk benefit needs to be balanced. There's a 10-month improvement in overall survival, but it comes with a cost and some additional side effects. If you look at the side effect, there seems to be advantage for darolutamide compared to the others. But as I said earlier, for me, it reinforces some very important conceptual ideas in prostate cancer management, wherein early intervention seems to be now consistently improving overall survival in this disease. With that, I'll thank the organizers again and give it back to the organizers to carry on with the meeting. Thanks so much.
Thank you, Senthil sir. As someone mentioned, amongst the best moderators in Earth and Mars too. And thank you all the panelists.
You floored me and I'm going back home today.
Thank you all the panelists. I will invite for a talk on olaparib, Dr. Chandra Gaudar as a speaker, who is Director Medical Oncologist, Akash Healthcare Private Limited, Delhi. He will be speaking on PROFOUND trial.
Thank you, organizers. Thank you, Astra, for giving the opportunity. So, shall I share my slides, or you will be sharing them? Hello, 1 second. Yeah, got the slides. Can everyone see the slides?
Yes, sir.
Yeah. So I'll be speaking on the PROFOUND trial. So just a background of the PROFOUND trial. We all know that we are moving away from what in the all tumors in one basket, or treating everything in one go. So to probably genomically profile that tumor and then probably target that and then use the targeted agent. So in that regard, the prostate is not behind now. Now we are inching towards that particular momentum. So we know that DNA repair gene aberrations, which are there in patients who have prostate cancer, be it regional or biochemically recurrent or a metastatic prostate cancer. 1/3 of them can have these particular gene abnormalities. So amongst that, the BRCA2 heads the list, which is more common, and then the BRCA1 ATM. So these three are more common compared to other HRR mutations, which I'll elucidate later. Next slide, please. So in that, even NCCN guidelines acknowledge that the prostate cancer is a heterogeneous disease, and hence classifying into various risk factors, and the outcome of these patients are completely different as far as the prognosis as well as the outcome is concerned. Next slide. With these points in mind, and the rationale of using PARP inhibitors in mCRPC came into vogue. So we know that despite significant progress in the systemic therapy, metastatic CRPC continues to be lethal. The median overall survival is to the tune of around 2 years plus. So mCRPC is molecularly heterogeneous, and up to 30% of mCRPC harbor deleterious alterations in DNA repair genes. So including those with the direct and indirect rules, so that is homologous recombination repair genes, HRR mutations. So these alterations confer sensitivity to PARP inhibitors, of which BRCA1, BRCA2, ATM are most well characterized. So the anti-tumor activity of these PARP inhibitors were learned from the other solid organ malignancies, specifically the ovary and breast cancers. Next slide. So with this background in mind, the PROFOUND trial came into vogue. It's a phase 3 randomized open label trial or in patients who carry HRRM, that is the homologous recombinant repair mutations in metastatic CRPC. So HRRM was done by Foundation 1. So patient who had a metastatic CRPC and had an HRRM mutations were randomized into two cohorts, the cohort A and cohort B. They should have been assessed by independent investigators as a radiographer of progression on either of one of the agents, like either a new hormonal agent, that's either abiraterone acetate or enzalutamide. So either of these agents they should have received for metastatic prostate cancer prior. The good performance status, they shouldn't have received any PARP inhibitors previously. Next slide, move ahead please. So they have been characterized into cohort A and cohort B. The cohort A consisted of a BRCA1, a BRCA2, and AT mutations, and the cohort B consists of other HRRM mutations, which I'll elucidate later. So, move ahead. So, they were randomized in 2:1 with to olaparib versus physician's choice treatment. The ones who has received abiraterone would receive enzalutamide in the physician's choice, vice versa. So, in either cohort A or cohort B, there is 2:1 randomized to either olaparib or physician's choice. Next slide. Move ahead. So move ahead, please. The endpoint of the study, the primary endpoint of the study was the radiographic progression-free survival by independent review in a cohort A. So this was a primary endpoint, as this consisted majority of the patients had this mutation consists the majority of the patients as well. Hence, the primary endpoint was radiographic PFS in cohort A. And the key secondary endpoint were the overall response rates in cohort A, and combined in cohort A as cohort B, the radiographic pre-progression free survival and time to pain progression in cohort A and overall survival in cohort A, and the safety and tolerability. So these were the key secondary endpoint. Next slide. So the PROFOUND trial, as I was talking about, the cohort A consisted of 3 mutations: BRCA1, BRCA2, BRCA, and ATM. As these are very common mutations that were found in the prostate metastatic CRPC from the earlier studies, and we also know that the early studies have done with these 3 mutations, and there was a benefit of using olaparib in them. So the cohort B, this was almost an exploratory analysis to check whether these other mutations would also be benefited by the PARP inhibition. So in that, all BRIP, CDK, BARD, CHEK mutations, and FANKL and RAD51, all these mutations, whenever we stand for that, we find some of these mutations, would they benefit also from PARP inhibitors? That was more of an exploratory, as the numbers of these mutations are very, very limited. Next slide, please. Next slide. So the baseline characteristics were well balanced between the 2 arms. This is a bit busy slide, but what I'll just draw your attention is that the age at presentation, age at randomization, we know that the prostate is a disease of elderly. We just see here in the first the row that patients up to 85, 86 years and up to 90 years were enrolled in the study, indicating that using olaparib in the elderly as well is going to be beneficial if they carry this particular molecular abnormality. So hence proving that even elderly can be have been enrolled in this particular study. So we also know that the metastasis at the baseline, the de novo metastatic disease, was present in around 23% of the patients. So which we know that patients with a de novo metastasis carries a bad prognosis compared to patients who have a locally advanced localized disease. And we also know the visceral metastases were included in around 30% of the patients. And patients who have alterations in the genes, that's the BRCA2 is considered the most, which constitute around 50% of the patients compared to other mutations. So this was the baseline character which I want to highlight. Next slide, please. Next slide. Also, what I just want to highlight here is that patients who have received a prior treatment. So if you just come to a fourth row here, a prior new hormonal agent, only enzalutamide was received in 42% of patients. Abira was have received almost in 40%, and both Abira and enzalutamide in around 20% of the patients. The patients also received a previous taxane, so almost 65% of the patients have received a previous taxane. So these we can understand by this particular slide that they are a heavily pretreated disease, and hence carries an importance that this molecule with an endpoint will be really helpful in this particular subset. Next slide. Next slide, please. So we all have, I already has elucidated that the mutations that have been carried are BRCA2, ATM, and CDK112. So these are most commonly involved mutations, almost constituting to 90% of the mutations which have been studied. The rest of them are less than 10%. Next slide. So coming to a primary endpoint, that is radiographic progression-free survival in patients with cohort A, that is BRCA1, BRCA2, ATM mutations. So I'll concentrate on cohort A first, and then the combined cohort A and cohort B. Primary endpoint first, and then the secondary endpoints. So there was a clinically meaningful benefit that's 7.39 months versus 3 months, almost doubling of the PFS, and which was with a significant hazard and hazard ratio of 0.34 and a p-value of less than 0.001. And if you just see the curves, early separation of the curves as early as around 8 weeks, so indicating the benefit of olaparib starting early, and at 6 months there is 59 versus 22%, and also at 12 months there's a significant benefit maintained with olaparib versus physician's choice. Next slide, please. So if you see the subset analysis, subgroups of the patients who had the BRCA1, BRCA2, and ATM. So whether the patient who have used a previous taxane or not, the measurable disease is there or not, visceral disease is there or not, and irrespective of performance status, irrespective of the age, ethnicity, all of them benefited from using the olaparib. Next slide, please. So if you see the secondary endpoint in a cohort A, that is the overall response rate. In an olaparib arm, 33.3% responded to a measurable disease. Some of the patients who had lymph nodal disease or visceral mets, so there the response was seen to the tune of 33.3% versus only 2.3% in a cohort A. Next slide. So at an interim analysis, olaparib had if you talk of overall survival analysis, so there was only interim analysis, and just on 20th of this month, there was a final analysis because number of events were insufficient in 2019 ESMO. Hence, there was an interim OS which was done, and that was also significantly better, 18.5 months in the olaparib versus 15.11 months with hazard of 0.64, was consistently good with at 6, 12, and 18 months, favoring olaparib in a cohort A. Next slide. So if we combine now I'll be talking about the secondary endpoints in the combined cohort A and B arm. So that is the clinically meaningful improvement in patients in patients who have been treated with olaparib, and this was the radiographic progression-free survival in combined cohort at A and B. We just see the magnitude of benefit is comparatively lesser, but still it's statistically significant, indicating that probably cohort B would benefit less compared to these three mutations, that is the BRCA1, BRCA2, and ATM benefited the most. Nonetheless, the other mutations also benefit, but the magnitude of benefit is lesser as the number of these patients enrolled were lesser. But this is an exploratory analysis. We need to know the more studies, and probably definitely we edge on giving treatment for the olaparib for these patients as well. Next slide, please. So if you just see the subgroup analysis of RPFS in both combined cohort A and B, it is not dissimilar to compare to only cohort A. All of them benefited whether they received a taxane or any kind of meds, and irrespective of the age, all of them seems to be better with olaparib. Next slide. So also the overall response rate in combined cohort A and B is magnitude of that response is compared to lesser. That was 33% versus 21% here. In cohort A, revealed in 33%. In cohort A plus B is 21% versus 4.5%. Next slide. So there is the OS in intention to treat population combined arm. So we know that OS was interim OS in the cohort A was better, and we know that the 80% of these patients, just one more point, the 80% of these patients crossed over to olaparib at the interim analysis because it showed a benefit. So despite 80% having crossed over to the olaparib arm, it showed overall survival benefit, indicating that still olaparib is beneficial at 6, 12, and at 18 months. And if you just see in quantitative terms, the median OS is 17.5 months versus 14.2 months with hazard of 0.67. Next slide, please. So this is the secondary endpoint of median time to pain progression, which is also significantly better in patients who have been used the olaparib. Next slide. So also the median time to pain progression was better in both cohort A and B arms. Next slide. So next slide, I'll just summarize the results of this in the next slides, please. Next slide, because of the paucity of time. So we know that the magnitude of benefit in different mutations, the BRCA2 benefited the most, and then followed by this. So the RPFS benefit is greater for olaparib compared to other physician choice in cohort A and B, irrespective of whether the patient has used prior taxane or not. Next slide. Next slide, please. So this is also the same. The prior taxane use did not differ because it's benefit. Next slide. Next slide. So the median duration of olaparib in cohort AB was definitely much more than the physician choice. So this is just a profound summary results where the radiographic progression-free survival for cohort A and cohort AB both were much better in olaparib compared to others, and other significant secondary endpoints were also better in olaparib arm. There's no impact of taxanes, prior taxane uses as olaparib benefited in patients who have also used the taxanes. Safety profile, we all know that with our usage of olaparib in ovaries, that the anemia as well as upper GI symptoms are nonetheless similar to what we have used in others. The anemia is more common as the patients in this here bone metastasis and the prior taxane usage would result in around 20% of grade 3 anemia in this particular trial. Next slide. So the adverse events. Next slide. Next slide, please. One more. Next slide.
Are the slides not moving?
Okay, they're not moving. So I think this summarizes the adverse events are not different from other diseases. So yeah, this is the previous slide. This is at March 2020 data cutoff at the ESMO 2020 virtual meeting has shown that the overall survival benefit of olaparib was significantly better compared to the physician's choice. The key takeaways are the PROFOUND is the first positive biomarker-driven selected phase 3 data evaluating targeted therapy in men with HRRM, MCRPC, and this was really beneficial, whether you consider the RPFS primary endpoint or the secondary endpoint. Despite more than 80% crossover, the olaparib did better in terms of OS, and the recent update also shows the benefit of overall survival, more so in BRCA1, BRCA2 ATM, and less pronounced in the other mutations. It's well tolerated, and the safety profile is generally consistent with that of seen in the other cancers. So next slide. with that, the guidelines also recommend testing the molecular profile, that is genomic profile in the prostate cancer, especially so in the metastatic setting, and then then recommend olaparib in that particular context. So with that, I thank you organizers, and thank you AstraZeneca for giving me a participate. Thank you very much.
Thank you, Dr. Chandragowda, for nice talk. I will hand over the next session to Dr. Samir Srirangwar to take it forward.
Thank you, Rishabh. Thank you, organizers. So after this excellent discussion on the topic of non-metastatic prostate cancer, we'll move on to the next session of with more interesting topic of metastatic prostate cancer. So I think we are already running very late, almost 45 minutes. So we need to go fast now. So I will first invite our chairperson for this session. First is Dr. Devendra Sharma sir. Is a director of CK Birla Hospital, Jaipur. Then Dr. Mukul Goyal sir is a consultant medical oncologist at Asian Research Institute, Jaipur. And next one is Dr. Lalit Mohan Sharma sir is a consultant medical oncologist at BMCH RC Hospital, Jaipur. So I will first hand over the session to Dr. Devendra Sharma sir. He will invite the speakers one by one respectively for their paper presentation. Dr. Devendra Sharma sir.
Yes, thank you very much. And first of all, in this discussion, I would have privilege to invite Dr. H.S. Advani sir, who is the father of medical oncology and the director, Department of Medical Oncology, Jaslok Hospital and Research Center, Mumbai. Over to Dr. Advani.
Advani sir, can you just unmute, please? Sir, can you unmute, please? Advani sir, can you unmute, please? Yeah.
Okay.
Please, sir.
Now
Yeah.
you can listen.
Yes, sir.
Yeah. Good evening, colleagues. I think all of you must be sitting here for quite a long time, and also this is a topic which has been discussed over and over again in all the meetings on prostate cancer. So there will be a lot of duplication. But I would like to now discuss a small area of managing the metastatic prostate cancer. As all of you know, that how do we manage the metastatic prostate cancer? The best way is the androgen deprivation therapy. And this androgen deprivation therapy is achieved either by bilateral orchidectomy or by giving the various agonist and antagonist for the LHRH. So one can really see that these are the standard treatment for hormone sensitive prostate cancer. And that has been going on for a long time, that all of us are using the either bilateral orchidectomy or the use of the androgen deprivation therapy in the form of the injections, which reduces stop the production of testosterone. This has been the major sort of a treatment for long, and then some of all these patients ultimately develop the hormone resistant prostate cancer. And that's a time we have got large number of drugs which are used, whether it is a docetaxel, whether it's abiraterone, enzalutamide, then cabazitaxel, mitoxantrone, and so on and so forth. All this, the hormone resistant prostate cancer is because of the multiple mutations in various genes which ultimately lead to the resistance. And that's where all these drugs are very useful. However, the most important part remains that when you start the treatment in the hormone sensitive prostate cancer, I think the important thing is to keep the prolongation of the hormone sensitivity for a long period of time. And that's where the patient will have a good quality of life. And there have been a lot of effort in that direction. one of the ways to add the docetaxel upfront along with the androgen deprivation therapy. And that was shown to be useful and superior to the alone androgen deprivation therapy. Then came the combination of ADT with the abiraterone. And that also showed that addition of abiraterone makes the difference. And today, what we are going to see in the trial is that how enzalutamide also when added to the ADT that can be better. So the background is that enzalutamide, which is a potent androgen receptor inhibitor, has been found to be useful in the hormone-resistant prostate cancer. That is well established. Many of these patients will respond for variable period of time. Also, in the various trials, it has been shown that there's a long-term suppression of the PSA after the use of enzalutamide. And that's where now we have got now hypothesis that enzalutamide in combination with ADT will show the affect the progression-free survival. Next slide. Next slide. So the ORCHIS trial randomized the patient to alone ADT with placebo versus the ADT with enzalutamide. So it was one-to-one randomization where enzalutamide was used in 160 milligram daily. Next slide. And I think next slide. If you look at all the criteria, you can see they were equally distributed, whether it's with respect to the ECOG performance score or Gleason score or localization of the metastasis and the prior therapy. Everything was absolutely equal in both the groups. Next slide. And look at the result. That radiographic progression-free survival was definitely superior to the patients who received the enzalutamide along with the ADT. So I think this has now established that how we can improve the progression-free survival in the patients who has hormone-sensitive prostate cancer. Next slide. Not only that, next slide. If you look at all the criteria, we can see that this advantage is seen irrespective of the various subgroup. So in subgroup analysis, the benefit is seen in almost every type of the patient. Next slide. Also, the PSA progression, which was the secondary endpoint, is also was delayed in patients with the who received the enzalutamide. Next slide. And thus suggesting that it is very clear that addition of the enzalutamide makes a big difference. Particularly, you can see how the overall response rate is definitely superior, 83% versus 63%. Next slide. And all this thing was achieved with very little of additional side effects. Next slide. In terms of adverse effect of special interest were the hypertension and some of the other fatigue, sometimes diarrhea, but they are all manageable with a very little really additional problem. Next slide. So what this trial show really that addition of enzalutamide to the ADT makes a big difference in managing the patient with hormone sensitive prostate cancer. And also maybe we may come up with the overall survival, which may be higher in such a group. Next slide. And thus, conclusion is very clear that enzalutamide with ADT significantly reduced the risk of metastatic progression over time versus the placebo and ADT. It is well tolerated, and in both the group, the quality of life was maintained over a period of time, and enzalutamide plus ADT should be considered as a treatment option with hormone-sensitive prostate cancer. So friends, what we have discussed is that in contrast to the condition like using the ADT along with the docetaxel or along with the abiraterone, this enzalutamide seems to be superior in terms of the acceptance as well as in terms of maintaining the quality of life. Thank you very much.
Thank you, Arjun sir. And now I would like to invite Dr. Bowman Dabar. He is a consultant medical oncologist, Fortis Hospital, Mumbai. Dr. Bowman, thank you.
Thank you very much for inviting me today to speak on this topic. And thank you, Advani sir, for forming a strong background for me. So today what I am going to talk on the results of the Stampede trial when we add docetaxel to androgen deprivation therapy, whether the tumor has low or high tumor burden. What are its long-term survival results? Does docetaxel work for low tumor burden or high tumor burden? These are the results of the Stampede trial. Next slide, please. Next slide. Next. So what is Stampede? Stampede is a systemic therapy in advancing or metastatic prostate cancer. It's a very innovative trial. It has a multi-arm, multi-stage trial. It utilizes one control arm and several comparative arms in order to provide evidence for inclusion of therapies beyond the standard androgen deprivation therapy. So to introduce this topic, the earlier Stampede trial, the docetaxel comparison arm in the primary analysis showed an improvement in survival. But here the patients were M0 and M1 were all included. And to this, I'll agree with Dr. Senthil, the M0 arm did not show an improvement by adding docetaxel as an adjuvant therapy. So in what Dr. Senthil and they were discussing, M0 arm in Stampede trial at least did not show by adding docetaxel there was an improvement. And since both M0 and M1 were included, the Stampede trial analyst decided to analyze only the M1 patients' data separately and to give them a flavor of metastatic burden, whether it's low or high risk. Does it make a difference? And of course, this is one of the large follow-up data that they have presented in this study. This was the need of R. Why? Because the earlier two trials, the Chartered and Getted, clearly showed, I would not say clearly, in fact, in a subgroup analysis showed that docetaxel should not be given in low metastatic burden, and docetaxel was useful only in high tumor burden. This gave birth to this study. This was 1,886 patients, as I told you, only M1 patients. Arm A was androgen deprivation therapy, and Arm C was androgen deprivation therapy plus docetaxel. As you can see, the number of patients, certain number of patients were excluded because retrospectively, when they tried to analyze the bone scans, some of the bone scans were not centralized or they were not reported the way it should be. The patients, the Arm A, as I told you, was the androgen deprivation therapy, and Arm C was androgen deprivation therapy plus docetaxel. And in both the arms, the patients were stratified as per the low tumor burden or high tumor burden, it was defined as per in the charter trial, which I'll show you in my subsequent slide. The randomization 20% was according to the hospital site, according to the age less than 70 or above 70, WHO performance status 0 or versus 1, 2, nodal involvement, negative, positive or unspecified, planned ADT, and usage of aspirin or other NSAID. Metastatic burden was assessed by whole body scintigraphy, CT scan or MRI staging. The high tumor burden as per charter trial was whether there was a presence of visceral metastasis or at least 4 bony lesions with at least one outside the vertebral body. The results of this trial show very clearly the overall survival, the results in the low tumor burden. As you can see here, the median survival was 76.7 months in the ADT arm, but when docetaxel was added, the survival jumped to 93.2, and well, this is in low tumor burden. Whereas in high tumor burden, as you can see, the numbers will be lesser because these are the patients who have high tumor burden, but still there was a significant benefit. The median survival of 35.2 months versus 38.9 months. The 5-year survival also jumped when we added docetaxel to ADT, 72% versus 57% in the low tumor burden, whereas in high tumor burden, there was improvement of 5-year survival by 10%. Yes. Next slide, please. And this is just an overall survival curve where you can see the separation, in fact, is much better in low burden versus high burden. And hazard ratio in low burden of overall survival is 0.76 compared to 0.81. Results here of the secondary endpoints in this trial were failure-free survival, progression-free survival, metastatic progression-free survival, and prostate cancer specific survival. As you can see, the hazard ratio in all the secondary endpoints was much better when docetaxel was added to androgen deprivation therapy. These are the adverse events, as you can see, where they are classified up to 1 year or beyond 1 year. If it was within 1 year, yeah, as expected, ADT plus docetaxel, the adverse events were higher, 21% versus 25, 3 versus 13%. And but after 1 year, the results, the adverse events were absolutely the same. So here, what we saw that adding docetaxel to androgen deprivation therapy, there was a clear statistically and clinically significant improvement in survival and delayed time to metastasis, irrespective of metastatic tumor burden. The earlier 2 trials, the J2 and the Chartered, which showed that that docetaxel was used only in high tumor burden. Just to give you a flavor of these trials, this was J2 was a trial of 385 patients, and median follow-up was 84 months. Chartered was a study of 790 patients with a follow-up of 54 months. The hazard ratio of adding docetaxel was clearly better. Sorry, this is not no. There was a clear evidence of improvement, and hazard ratio was 0.88, whereas in Chartered it was 0.72. In Stampede, in fact, it was in between. But see the number of patients in Stampede, 1086, and a very long follow-up of 78 months. In prior subgroup analysis, as I showed you, docetaxel was recommended only in high tumor burden. But what was the reason? In both these trials, 25% of the patients were enrolled as metastatic disease had received previous radical treatment. And we know that that these patients who develop metastasis after radical local treatment have a different natural history than those who present with M1 disease de novo. In Stampede trial, the M1 patients were de novo. 95% of the patients were de novo M1 metastatic disease. And we know that none of the trials where androgen receptor pathway targeting agents that were used like abiraterone, aflibercept, or enzalutamide have shown any heterogeneity of effect by metastatic burden. Here, just to revise, in the Stampede trial, we saw the absolute gate in 5-year survival in low metastatic burden, 57 to 72% by adding docetaxel, whereas in high metastatic burden, as I told you, 10% improvement in 5-year survival by adding docetaxel. So to conclude, docetaxel plus androgen deprivation therapy improves the overall survival, failure-free survival in newly diagnosed metastatic hormone-naive prostate cancer, regardless of metastatic burden. It should now be considered as a first-line option, regardless of stratification of disease burden. Thank you very much, and I hope I've finished in my time.
Thank you, Dr. Bowman. And now I would like to invite Dr. T.P. Sahu, who is a consultant medical oncologist, Silverline Hospital, Bhopal.
Hi.
Over to Dr. Sahu.
Yeah, good evening. My slides are visible and I'm audible, I hope.
Sir,
yeah.
I think I request all the speakers to stick to the time because we are actually very late.
Yeah, so should I start?
Yes, sir, we can start.
Yeah. So over the next 5 to 6 minutes of the allotted 7 minutes given to me, I will be speaking on a trial that's a CARD trial, which is on cabazitaxel versus abiraterone or enzalutamide in a metastatic prostate cancer. And this is on a setting where they have already been failed to docetaxel, they have been exposed to docetaxel and already have received one of the androgen receptor inhibitors. So the background is, although patients with the metastatic castration-resistant prostate cancer have several treatment options, there are actually few data exist about the treatment sequencing in this subset of patients. In the previous study, have also suggested there's a partial cross-resistance between the androgen signaling targeted inhibitors that's present. 4 of them are actually present. In India, we use 2 of them and docetaxel. And the androgen signaling target inhibitors, docetaxel, are frequently used in earlier stage of the disease, as the previous speakers have alluded to. We have been starting to use it along with the androgen deprivation therapy. And it is likely that most patients who are considered to be candidates for chemotherapy would have received both of them or in either order, both the androgen signaling the targeted inhibitors. So to address the question of the patients who have been exposed to docetaxel and also have failed one of the androgen receptor inhibitors, whether to give cabazitaxel versus or to give abiraterone or enzalutamide, depending upon which they have been received earlier. So here, this is a patient with metastatic castration-resistant prostate cancer who's progressed within 12 months of a prior androgen receptor targeting agents. The androgen receptor targeting agents could have been given before or after docetaxel, but they should have been exposed to 2 lines of therapy, and there should be castration-resistant prostate cancer. This was named the CARD study design. It was a multicentric randomized open-label study with a 3 years enrollment, and the median follow-up was about 9 months. So the primary endpoints were the radiological PFS, that's the primary resistance, and the secondary endpoints were the OS and the PFS and the PSA response. Sorry, excuse me. The characteristics of the patient, around 33% of the patients were beyond the age of 75 years. So they used the elderly because prostate cancer, normally all the trials have this subset of patients. Around 20% of patients had a visceral metastasis. And at the time of progression of the entry study, the PSA was only elevated around 8% of cases. The radiologically with no pain are around 17% of cases, but there was pain in a significant around 2/3 of cases, and more than half were have the high Gleason score, and M1 at diagnosis were around 40%. So look at it. Just to tell you the timing of the previous androgen signaling receptor before and after docetaxel, around before docetaxel around 40% and after docetaxel around 60%, and that's what is the data of the previous treatment. So looked at the imaging based PFS, which was this primary endpoint of the study. It proved with a significant value in favor of cabazitaxel with a hazards of 0.54 that it was superior to any of the androgen signaling target inhibitor used. The abiraterone used the enzalutamide once used the abiraterone, and both of them it was superior in favor of cabazitaxel, 8 months versus 3.7 with a hazards of 0.54. The PFS was also statistically significant, the hazards again of 0.52 in favor of cabazitaxel, and the OS was also significant to the hazards of 0.64 in favor of cabazitaxel versus the androgen signaling targeted inhibitors. The results of the radiological PFS in the subgroup analysis, there was nothing as a subset which we could tell that this is the subset which will not benefit. So every group really had a benefit. It is across subsets that cabazitaxel showed superiority. For the skeletal events, because majority had a pain and bone mets, so the cabazitaxel did not reach the median, while the other arm had 16.7 months to the first symptomatic skeletal event. So again, this was a superior in that. Safety, I'm not going to allude into much because we have been using these drugs and nothing new to tell about that. So to conclude, in conclusion, cabazitaxel leads to a longer imaging based PFS than abiraterone or enzalutamide among patients who have metastatic castration-resistant prostate cancer who had previously received docetaxel or alternative androgen signaling targeted inhibitors. Cabazitaxel improved the PFS, radiological PFS, the OS, and also the first sign to a major skeletal event. So what do we take it from? All of us know that the upfront dosi versus cabazitaxel, the Frustana trial showed that cabazitaxel was not superior. We also know that a patient with a poor or early lack of response, here it is important for us to remember, this is the editorial which I'm quoting, that this could be a sequencing that we already knew. There's evidence to that now. Early patients who do not respond beyond 18 months to a hormone receptor inhibitors like enzalutamide or abiraterone, to follow up with the second agent of this group is not the right option. The best option is to go for chemotherapy. What about PARP inhibitors? Because now also we have PARP inhibitors in prostate cancer. To end it off with that, you have olaparib and rucaparib. There are two drugs that are approved. So if you have exposed a patient to abiraterone and enzalutamide, no chemotherapy, the studies of olaparib has been positive. But if you have exposed a patient to chemotherapy and the AR targeted therapy, then rucaparib is the drug as of now because of the evidence it has gathered. So the last point, do we have to look at AR-V7 detection? Yes, that would be helpful. If you have a mutation in this part, then probably you would not be and not looking at a therapy which is based on androgen receptor. And that is what it should be ending up with. You look at the previous progression-free period, you look at the AR-V7, you look at the use of PARP, whether the BRCA mutation or the other mutations which are linked to the BRCA family is there, then you should sequence your therapies. So that's it. Thank you. And I hope I finished in my time. Thank you.
Thank you, Dr. Sahu, for finishing in time. Now I would like to invite Dr. Bharat Vaswani, who is a senior consultant medical oncologist, Yashoda Hospital, Hyderabad.
Good evening, friends. Let me thank the organizer for such a wonderful conduct. The study that I will be discussing has lot of ramification in the clinical practice. In fact, lot of us are doing it, but we did not have any robust data. Now, for the first time, we are having some data in a prospective setting that tells us that what we are doing. Anyway, I can tell you everybody is doing on some patient or the other, but this is the first prospective study to say or to prove what we are doing is in fact right. So the study that I am discussing today is a optimal sequencing of enzalutamide and abiraterone acetate plus prednisolone in metastatic castrate-resistant prostate cancer, a multicentric, randomized, open-label phase 2 crossover trial. Now, this was published online in the November edition in Lancet. So basically, again, an open-label phase 2 crossover trial done at 6 centers in British Columbia, Canada. Now, to understand the importance of this study, let us understand two things. All of us know that abiraterone as a first-line treatment in metastatic castrate-resistant prostate cancer, we have a phase 3 data, COW 302. Again, with enzalutamide, we have a phase 3 data, that is a PREVAIL study. Both studies showed that this drug improves radiographic progression-free survival and overall survival. But we don't have any study which is direct head-on between abiraterone and enzalutamide. So you can use any of the two, but you don't have any prospective study to study that. The second most important thing is, if you have used abiraterone, can you use enzalutamide or vice versa? Now, basically, there is no robust data. There are 3 retrospective studies which has been conducted. 2 studies gave enzalutamide as the first and abiraterone as the second line. The PFS response was less than 10%, dismal response. The third retrospective study used abiraterone first and then enzalutamide, also had a limited response. But again, all 3 were small retrospective studies. So as a practice, we do it, but we did not any robust data. And that formed the basis of this study. So it was the first randomized head-to-head comparison of abiraterone plus prednisolone versus enzalutamide in metastatic castrate-resistant prostate cancer, first prospective. And the second most important thing is, does sequence matter? So this trial also compared best treatment sequence and is there a second line activity of any or both the drugs. So all newly diagnosed prostate adenocarcinoma without neuroendocrine differentiation with a castrate level of testosterone with rising PSA were included in 2 arms. So group A had abiraterone followed by enzalutamide. So abiraterone 1000 mg once daily with prednisolone given till confirmed PSA progression or any radiotherapy given, unacceptable toxicity or withdrawal. Around 101 patients. Once they progressed, they were given enzalutamide. So A was abi followed by enzalutamide. In the group B, it was the other way around. So they started with enzalutamide and on progression gave abiraterone. Now, when you look into the primary endpoint of the study, it was like a PFS2. So the primary endpoint was start of the treatment to time to second PSA progression. So you gave a treatment, on progression gave the second line treatment, and when they progress, what is this time? And the second primary endpoint was a PSA response more than 30% decline on second line therapy. So they wanted to look whether second line really improved the PSA response. Now, when you look into the results of the study, first time to from the start of first line therapy to second PSA progression, and what they observed was for those patients who are given abiraterone first followed by enzalutamide has a better PFS2. So the PFS2 improved from 15.2 to 19.3 with the absolute gain of 4.1 months when abi was followed by enzalutamide rather than other way around. So the first trial, there is definitely importance in significance. So the second primary endpoint was there a PSA decline during second line therapy? So when you look into it, in group A, the second line drug was enzalutamide. So when enzalutamide was given in a second line, there was 36% patient who had a PSA decline of more than 30 versus only 4% when abiraterone was given in a second line. What about overall survival? So in group A, there was a numerical improvement in overall survival from 24.7 months to 28.8 months. So there was again a 4.1 months improvement in OS, which was numerically important, but statistically not significant. Now let us look at the secondary analysis. Look at the right side of the curve first. Suppose if you use enzalutamide as a first line or abiraterone as a first line, so no added advantage. You can use both the drug in the first line with the time to PSA progression is around 11 months. But what is more important is if you are using enzalutamide as a second line from abiraterone, the PFS response is 3.5 months, whereas it is only 1.7 months when you are using abiraterone in the second line. And this is statistically significant with a very significant hazard ratio of 0.42. What about PSA decline during first line? So first line in those patients where enzalutamide was used had a 82% of patients had PSA decline versus 68% in abiraterone. So although the time to PSA progression is equal, but suppose if you want to give only one drug, then enzalutamide, more patients will have a PSA response as compared to abiraterone. Now coming to side effect, does side effect matter? So there were serious side effects in 15% of patients in group A, that is abi followed by enza, versus 20%. But these were minor and there was no treatment related serious adverse events. So in terms of toxicity, it is equivalent. Now, what is the reason why enzalutamide is working in the second line and why abiraterone is not working in the second line? So what they suggested is, once you give the drug, there are mutations involving the ligand binding domain of the androgen receptor that we know that emerge during the course of this therapy. Now, when you look into abiraterone with prednisolone, there are 2 common mutations that come, L702H and 7T7878A. And in both the mutation, enzalutamide retains androgen receptor inhibitor activity. So once you give abiraterone, there is a mutation, they are still sensitive to enzalutamide. Whereas when you are giving enzalutamide, there is a amplification of the androgen receptor, and here abiraterone is also resistant. So the resistant mechanism is not overcome by abiraterone. So what they concluded is time to second PSA progression was better for the sequence of abiraterone followed by enzalutamide, driven by the second line activity of enzalutamide. There is no difference in time to first PSA progression. So if you are using a single drug, you can use any of the two. But enzalutamide retains clinical activity as a second line drug following abiraterone, whereas abiraterone retains no single line activity following enzalutamide. Of course, what Sahu sir discussed and everybody, you have other drugs also. So because of this modest response to second line enzalutamide, you have other available appropriate options that you can try when the patient is progressing on first line androgen receptor pathway inhibitors like taxanes and radium. But this result for the first time in a prospective supports the role of enzalutamide as a second line androgen receptor pathway inhibitor, but not for abiraterone. So last itis clinical implication, this is my take. Definitely all of you have patients who have never taken any of these tablets and sensitive because they are with urologists and you have never seen them. Now they are coming to you in your clinical practice and you will see a subset of patients who will not desire to take a IV chemo, or you may not think that he may tolerate IV chemo. So if in a real life situation, if the patient is not fit for IV chemo or is non-willing for the same, in order to maximize the best use of the available resources you have, choose sequence of abiraterone followed by enzalutamide for better overall survival, better PFS2, and this is the first and the only randomized study which is available till now in a prospective setting. I thank you all for a patient hearing.
Thank you, Dr. Bharat. Now I would like to invite Dr. Sandeep Basu, who is the head nuclear medicine academic program, Radiation Medicine Center, Tata Memorial Hospital, Parel, Mumbai. Over to Dr. Sandeep Basu.
Yeah, so good evening to all. Can I just do the screen sharing? Yeah, okay, thank you. At the outset, I would like to thank the organizers for inviting me to participate in this excellent academic activity. So just before we go to the clinical nuances of therapy trial, just a brief recap of what is PSMA all about and what is PSMA theranostics. We are all using gallium PSMA for scans. So PSMA is a transmembrane protein, which is type 2 transmembrane protein, which is 100 to 1000 times overexpressed in cell membranes of prostate cancer. It is overexpressed at a higher grade with metastatic disease and castration-resistant prostate cancer. We typically use gallium PSMA HBED-CC for the scan, which is PSMA 11. And when it is labeled with lutetium PSMA 617, it can be targeted for therapy. Now, what is the theranostics? The fundamental principles of theranostics are that you have a scan, which is gallium PSMA PET-CT. As you see, this patient, we started in Radiation Medicine Center, Tata Hospital premise in April 2017. Roughly in 3 years, we have treated 200 patients of MCRPC, just to give you the background. So you have a gallium PSMA scan, and this is lutetium PSMA post-treatment scan. You see exact same distribution, and lutetium is a therapeutic radioisotope. So the strong point of this therapy is its excellent tolerability and very minimal side effects. Just to show you an example, this patient has undergone treatment with 9 cycles docetaxel and abiraterone previously and had a progressive disease. This is the gallium PSMA scan, and after 3 cycles of PSMA, lutetium PSMA therapy, this is the gallium PET-CT. This is taken from our series. So there is a lot of encouragement with respect to lutetium PSMA peptide receptor radioligand therapy in prostate cancer in MCRPC setting. So what has therapy P study? This is an ongoing trial with some preliminary results yet. So it's It's a kind, it has been, the eligibility in this trial was MCRPC patients who have undergone docetaxel treatment and had shown progressive disease. And that is the time when the patients were randomized. It was a 1:1 randomization. And if you see, there was a lot of stress on the imaging component. So you have to have at least more than 20 sites of disease in this trial to get 20 sites of disease and resistant metastatic following post-docetaxel. The SUV max in PSMA PET CT has to be more than equal to 20. And you always require to do dual tracer PET CT to select. I just tell you the example how they have done is, see, in our setup, we do now 5 kinds of a subset, and this will be a major a bit of an ahead of time, but a very important thing is that we are going to probably individualize which patient is going to go by dual tracer PET CT. And if you see, this is the group of patient where it was eligible. So you have a PSMA which is showing very high uptake, FDG does not show anything. So this is a group, one subset where this is a congruent PSMA PET CT. These are the 2 groups of patients who were eligible with PSMA, lutetium PSMA and cabazitaxel randomization. Whereas this group of patients, when you have FDG uptakes more than PSMA, these are the patients who will not be benefited with PSMA therapy. So in this trial, what they have done is there should be no discordant FDG plus PSMA minus disease, which will be centrally reviewed by a committee. And by that way, they will do a randomization between lutetium PSMA 617, which will be giving 200 millicurie 3-monthly, 6-weekly treatment. In our setup, most of the setup, they are giving between 2 to 3 monthly. But in this trial, they have used this therapy every 6 weekly, whereas cabazitaxel 3 weekly, 20 milligram per square meter as per the standard norms. And then post-treatment SPECT CT, if you find a very good response, as I showed you, you can see like this patient within 3 therapies, if you have seen with LU PSMA has almost 0 lesions in gallium PET CT. So if you get this kind of a results, then one should suspend treatment and reconsider upon the progression. Taking that, I just give you a small insight into this is, if you see in our experience, what we see, if you see this kind of a lesion where FDG uptake is high, in some of the lesions, here it is partial discordance where FDG is high, we find that there is less response. So just trying to give you the insight, this is one study that was published from our group of Radiation Medicine Center, Tata Hospital. Amit and Kumar both are co-authors for this from and one of our MD student who have published. And if you see, as the FDG uptake goes up, the therapeutic efficacy of PSMA goes down. So the progressive disease in our set is when you have a FDG SUV of 15.1 is 80% versus 40% when it is up to 5. So taking that into the background, the therapy trial has randomized 200 patients, and it has been divided into 19 and 101 nearly equal, and ultimately 98 patients were treated with LU PSMA arm and cabazitaxel with 85 patients. Now, the primary endpoint of this therapy trial was PSA response, and as per the PCWG criteria, was defined by PSMA reduction of greater than 50% from baseline. Secondary endpoint was PSA progression-free survival and adverse events. The things that were not are there in this trial but not reported. It is a relatively new ongoing trial. So objective tumor response by RECIST 1.1. And as we see, the symptoms and quality of life were seen by PEN response and PEN PFS, whereas the imaging was done by RECIST 1.1 for response and radiographic PFS, and then after all, the health-related quality of life and overall survival. So these were not reported when the preliminary results were reported in this March 2020 ASCO trial. So just to show
only
you,
one minute left.
Yeah. So if you see, this has a median follow-up of 13.3 months, and the data was presented in 31st March 2020, the cutoff. And if you see more or less they were matched in all respect, both in the cabazitaxel and LU-PSMA arm. The Gleason score divisions also were very well matched. And just to show you the preliminary result from the primary endpoint, the PSA response was 37% in cabazitaxel arm, whereas 66% in LU-PSMA arm. So there is a 29% absolute increase in LU-PSMA therapy arm. And the overall, the safety results were also published, and the safety results is that you see neutropenia, thrombocytopenia, and dry mouth and dry eyes in LU-PSMA arm, which is this, and the diarrhea and dysgeusia and neuropathy in the cabazitaxel arm, that these are the percentages, overall 54 and 35. So with this preliminary result, the final impression by the group was in men with progressive disease following docetaxel, LU-PSMA was more active than cabazitaxel with fewer grade 3, grade 4 adverse effects. And PSA PFS, I have not shown this because it was a preliminary, the carb separation was good. And it represents, so they concluded that LU-PSMA represents probably a good potential new class of therapy for men with MCRPC. Thank you.
Thank you, Dr. Sandeep, for excellent talk. And now, the last talk of this session, I would like to invite Dr. Bharat Rangarajan, who is a consultant medical oncologist, hemato-oncologist and stem cell transplant physician, Kovai Medical Center and Hospital, Coimbatore. Dr. Bharat Rangarajan.
Thank you, Dr. Devendra, and thank you, Dr. Tarachand, for the invite. I hope I'm audible.
Yes.
I will be, can you just share my slide set, or should I share it? Yeah, I think the slide sets are being shared. So this is a presentation on the pain response and the pain-related, health-related quality of life between in metastatic castration-resistant prostate cancer who were treated with second-line therapy. And the comparison was, the trial originally published was a comparison between cabazitaxel and enzalutamide or abiraterone, the alternate therapy, whichever was used. And these patients were either post-docetaxel or post-first-line hormone therapy with the alternate agent. This publication focuses only on the pain response and the health-related quality of life. So to go ahead, next slide, please. Next slide, please. So the CARD study, which was published in NEJM in December 2019 by Witt et al., they reported superior PFS and OFS with cabazitaxel versus enzalutamide. In patients who had progressed on the first-line therapy. The first-line therapy could be docetaxel or one of the hormone agents, abiraterone or enzalutamide in the other arm. This trial looks at the health-related quality of life and pain scores. Next slide, please. Pain response was defined as a decrease of more than 30% from the baseline and with no increased analgesic use. Health-related quality of life was assessed using the functional assessment of cancer therapy, the FACT-P specific for the prostate questionnaire. Patients were evaluable if they had received at least one cycle of cabazitaxel or abiraterone and had a baseline FACT-P score which was measurable. Next slide, please. A clinically meaningful improvement or deterioration of the FACT-P score was defined as a difference of plus or minus 10 points from baseline. That is plus 10 points for improvement or minus 10 points for the deterioration. And clinically meaningful health-related quality of life and pain response were confirmed at 2 consecutive evaluations around 3 weeks apart on the on-treatment period. Next slide, please. Of the 255 patients randomized, 172 had moderate to severe pain at randomization. So these were the patients who were taken up for assessment. Pain response and health-related quality of life was accessible in around 111 of these 172 patients, that is around 86%, and 108 for the cabazitaxel and the abiraterone arms. Pain response was around 45.9% for the cabazitaxel arm and around 19.3% for the hormone therapy arm, which was statistically significant, which is also numerically a big, almost more than double. The probability of not having pain progression at 12 months was around 66% for the cabazitaxel arm, whereas it was only around 45% for the hormone therapy arm, which was also statistically significant with a good hazard of 0.55. Improvement of the total FACT-P score from baseline was reported in 25% of patients, whereas just 22% in the, so that was almost same, the numerical percentage of improvement. The FACT-P score was maintained or improved in 75% of patients in the cabazitaxel and in the ATRA arm, and deterioration of FACT-P from baseline was also reported in the nearly same number, 22 versus 24.6%. The median time to FACT-P deterioration was longer in the capacity. This was significant, was longer in the chemotherapy arm versus the hormone therapy arm. Next slide. So this is the Kaplan-Meier for the survival endpoint, which was initially published in 2019 in NEJM. The PFS and the OS, primary endpoint was the PFS, was significantly improved in the cabazitaxel arm compared to a hormone arm with a hazard ratio of 0.54. And the OS also had a hazard ratio of 0.64 favoring the cabazitaxel arm with a significant p-value. Next slide, please. So the pain response, which was the what was looked at this presentation, there was a 45% pain response in the cabazitaxel arm versus only a 19.3% response in the hormone therapy, that is abiraterone or enzalutamide. And the probability of no pain progression was also better across in the cabazitaxel arm compared to the abiraterone or enzalutamide, that the hormone therapy arms. Next slide, please. So cabazitaxel was associated with greater pain response and delayed pain progression versus the hormone therapy, that is abiraterone or enzalutamide, and was, however, they were associated with similar trends in the FACT-P questionnaire, and they were associated with similar trends in the health-related quality of life. But what was notable was the duration to deterioration in pain was around 14 months versus 8.6 months in the hormone therapy arm. That is, chemotherapy had a longer duration to deterioration of pain scores. Next slide, please. Thank you very much.
Thank you, Devendra Sharma sir, and thank you all the speakers for their super presentation. So now we'll move on to the panel discussion of metastatic prostate cancer. For that, I invite Dr. Shyam Agrawal sir. He's the director of Department of Oncology at Sir Gangaram Hospital, New Delhi. He's the moderator for this discussion. And I invite Dr. Kumar Prabhas sir, professor and head of Department of Medical Oncology, TMH, Mumbai, as a panelist. Then Dr. Amol Dongre sir, he's a consultant medical oncologist at Alexis Hospital, Nagpur. Dr. Arun Chandrasekhar, and he's a medical oncologist working in Aster MIMS, Kerala. Dr. Ankit Agrawal, consultant medical oncologist, Gitanjali Hospital, Jaipur. Dr. Nikhil Pandey, he's a consultant medical oncologist at American Oncology Institute. Now he's in HCG Hospital, Nagpur. Then Dr. Ranjit Sahu, Department of Associate Professor at Department of Medical Oncology, AIIMS, New Delhi. Dr. Abhishek Singh, he's a director and head of Department of Medical Oncology, Chandan Hospital, Lucknow. And Dr. Dinesh Gupta, he's a consultant medical oncologist, Narayana Hospital, Jaipur. So over to Shyam Agrawal sir for the panel discussion.
Okay, good evening and thank you organizers. Can I have the first slide? So I think the idea is to have a discussion on prostate cancer to put things into perspective. So before we, we're talking of metastatic prostate cancer. So my first slide says regional prostate cancer and how do you define that and what is the approach before we go on to the proper metastatic disease. So Dr. Ranjit Sahu, are you there, sir?
Sir, he's not there, sir.
Sir, I think he's not there.
Okay, Dr. Dongre from Nagpur, please. Dr. Amol Dongre.
Hi, sir. Hi, I am there. Hi,
So
good
your
evening.
comments on, going in for the thought for regional prostate cancer. So Amol, are you there?
Sir, sorry, sir. I didn't get. I just joined, and I mean, I don't know. Sir, what happened, sir?
So the question is, when you're
Yes.
looking at a patient with metastatic prostate cancer,
Yeah.
so if the disease is confined to the pelvis, so do you look at that angle of regional prostate cancer versus a widely metastatic disease? How do you look at your patients with metastatic prostate cancer?
So, well, sir, once we label these patients metastatic prostate cancer, then obviously, I mean, we look into that only stage 4 metastatic. I mean, I didn't get what exactly what you wanted to ask, like regional prostate cancer. I'm not getting this, sir. I'm sorry.
If you look at the NCCN guidelines,
Yeah.
they divide the prostate cancer metastatic disease into regional prostate cancer versus. Can I have the next slide? Is there a comment from any of the panelists there? Dr. Arun or Dr. Ankit Agarwal?
Yes, sir. I think what I look at is oligometastatic versus something less than maybe 5 met, something that can be targeted, versus something that's diffusely metastatic. That's what I'd look at, and also the low burden and the high burden. These are the two questions I would.
Now we'll come to that, but the idea of discussing this regional thing is if somebody has. Yeah, please.
Sir, this is Abhishek this side from Lucknow. So
Yeah.
I think regional prostate cancer, we need to have a newer addition in the NCCN guideline. It says that those cancer which are proceeding beyond the prostate and they are involving the local sites or along with the lymph nodes. And according to a SEER review, they say that even in this setting, the 5-year survival is almost approximately 100%. So there are some variations in treatment that we have to look into this particular entry, which is a newer addition in the NCCN guideline.
Right, absolutely. So I think that was the idea of putting this slide here. If you look at the regional, for example, as he rightly pointed out, that if the disease is going even beyond the prostate region and it is, involving the regional nodes, so the treatment, especially if your expected patient survival is more than 5 years or the patient is symptomatic, one should consider, external beam radiation along with ADT, which is the preferred regimen. So rather than, if you have only lymph node metastasis in the pelvic region, I think a lot of people are only happy with ADT with or without abiraterone. But I think the role of EBRT cannot be ignored. That was my point, which I wanted to put across. So any thoughts from Dr. Nikhil or Dr. Ankit? Can you go back, please?
Yes, sir.
Sir, yes, sir.
Dr. Ankit here.
Yeah, Ankit.
Yes, I think regional prostate cancer also needs to be taken care of, just like prostate cancer, which is non-metastatic. I think EBRT plays a very important role in these patients. Obviously, ADT has its own role. We should be we should be offering EBRT to these patients also. They should not be treated as a widespread disease.
Right. And I think this is also important to understand that if the expected patient survival is less than 5 years and the patient is largely asymptomatic, well, then it could be ADT alone or observation rather than subjecting these patients to radiotherapy. So our practice, I'll tell you, for example, today I saw a patient whom I've been treating for the last 6-7 years. This patient has prostate cancer and this patient had a lymph node in the para-aortic region. So it is even beyond the pelvic region. So 6 years ago or 7 years ago, we put the patient on ADT and patient has now, the PSA has gone from 0.6 to 0.8 and the and we saw the node, which was, earlier 5 centimeter, had gone down and now it has started increasing. So, my thought was to consider a radiation for this individual rather than adding a abiraterone, because 7 years ago, the patient is on Zoladex. So the thought is whether to give abiraterone or to, think of local radiation. So I have sent the patient after discussion with the radiation people because he's still like 60, 65 years. And so, the point is to consider radiation therapy for patients who have regional disease instead of just thinking in terms of hormonal therapy. So that is the point I wanted to bring in this particular area, this slide. So any comment from anybody before I move on? Okay, I think can we move on to the next slide? So this is another point which I think has not been discussed, but then the issue of, you see here, risk group is regional on metastatic disease. And we're talking about germline testing, which is recommended in both the groups. And for molecular and biomarker analysis of the tumor, especially recommended for the metastatic disease, which is M1, for HRR, or consider tumor testing for MSI and the mismatch repair deficiency. So this is an important test which I think we are missing at this point in time. So I want the comments from, from Abhishek. What do you think? So are you doing this test?
Sir, no, I don't do this test because practically if we want to utilize these tests in our clinical practice, we should offer if something which comes as indicated according to the molecular test, if some tests are positive. So I don't know whether treatment affordability and all, because the reason where I practice, affordability would be a problem. So generally I don't do, but yes, it is recommended. So we should do it.
Right. So I think any other comment? I agree with the funding part. Although the MSIs become fairly readily available, but yes, HRR is very expensive. That which is the homologous recombination gene, which is the HRRN. Any other thoughts here before we move on?
So if the patient can afford to take the immunotherapy or the olaparib, then that's when we proceed with testing. But if a patient is not able to afford, then as you said, as Dr. Abhishek said, we've kind of I don't tell them about this actually.
Right. So I think one of the Dr. Sahu made this point in his presentation that PARP inhibitors have been approved. So keeping that in mind, so not only the germline testing in the blood, but also on the tumor. So one should consider doing the HRR and the MSI. So next slide, please. Just a word about intermittent ADT. Who's following intermittent and who's following continuous ADT? So any thought process there? Because Dr. Amol Dongre, Dr. please.
So I'm following mostly continuous ADT. I'm not following intermittent ADT.
So continuous. Abhishek?
Sir, I follow continuous ADT, but if patient is having good compliance and he is committed to routine follow-up with PSA, testosterone and radiological follow-up, I might consider using intermittent ADT considering the non-prostatic side effect profiles. So,
Great.
but my practice is continuous ADT.
Yeah, Dr. Ankit and Dr. Arun, please.
So I'm also not practicing intermittent ADT as of now. It's mostly I've been using continuous ADT.
Next slide, please. Next slide.
Same thing here, sir. I've not had too many side effects.
So this is the from 2020 NCCN, a phase 3 trial that compared intermittent to continuous ADT showed that intermittent ADT was not inferior to continuous ADT with respect to survival, and quality of life was better for the intermittent ADT arm. So, this is the latest from the NCCN. It can be considered, although you have to read in between the lines to decide, whether to give intermittent or continuous ADT. So there isn't any consensus, but if somebody is doing intermittent ADT, perhaps is not incorrect. Next, please. So now coming to the hormone-sensitive prostate cancer, the approach and the factors. The next slide. So here is a patient with metastatic disease. Gleason score is 9, and patient has multiple bone disease and lymph nodes. So what do what are the factors which make you decide or choose your treatment? Abhishek, please. Next slide.
Sir, I think before this stampede result has come, probably this low risk and high risk would have made difference. But as the results are there that even in low risk disease, there is a benefit of adding docetaxel or abiraterone. So probably, yes, of course, we can prognosticate, but for treatment purpose, I think there is no much difference right now. I mean, high risk burden disease, definitely we should treat along with ADT, we should add on docetaxel or abiraterone. Low risk, we can take decision based on the discussion.
So as you see here from the charted, one of the following is there for high risk, which is presence of visceral metastasis, more than 4 bone lesions, with more than 1 beyond the vertebral bodies and pelvis. And the latitude, the definition is 2 of the following: Gleason score more than 8, more than 3 bone metastasis, and measurable visceral metastasis. So I think one needs to look at those factors. So Dr. Arun, any comment on high risk versus low risk disease in terms of approach?
Yes, means what Dr. Abhishek said, that the new trial says that docetaxel can be used in low risk, but I think a low risk with Gleason of 6, 7, perhaps with a low PSA, that's a patient I would avoid docetaxel. If I had a patient with low burden disease as per charted, they don't mention the Gleason and the PSA, but you have a high Gleason, high PSA, that's the low burden patient that I would give docetaxel to. Otherwise, I would, stick with a low PSA, low Gleason, and a low burden. I would still go with abiraterone.
Yeah, Dr. Ankit.
Sir, I think I'll look at the performance status, whether he'll be able to tolerate docetaxel, and if he's willing to take docetaxel, performance status being good, I think I'll prefer docetaxel in this patient, followed by the second line once he progresses after dosi or after 6 cycles.
So Dr. Amol,
Yes,
how do you?
so definitely PSA of more than 180 and Gleason score 9. I would go for docetaxel, obviously based on the performance status of the patient, but my choice would be to give docetaxel in this patient.
So a patient who has extensive disease will be, and if the performance status is acceptable and is good, well, then you would go for the use of docetaxel. Otherwise, it would be abiraterone, right? So what about enzalutamide? No takers for enzalutamide here? Yeah, Abhishek?
So, enzalutamide, I'll keep, I'll reserve it for next, whenever it is required. Because first line, I'll definitely use abiraterone instead of using enzalutamide. Looking into the recent results of sequencing of this thing. So that strategy I might use for the later progression.
So
Sir, if I may, I think Dr. Vaswani showed a very good data which said that sequencing with abiraterone followed by enzalutamide would be a better option as compared to enzalutamide upfront.
Absolutely.
Although
So
it was only phase 2.
Right. I think looking at the data as it stands today, and even the cost factors involved, because enzalutamide still is more expensive. Plus, I would like to sequence abiraterone first and enzalutamide later, and if docetaxel would come in, people would think.
So just wait for a minute or so. We'll be back with the slides. Just wait for a minute.
I think that's quite clear today with the availability of the data. Amol, what do you is your sequence in most of patients of metastatic prostate cancer?
So my sequence could be as I mean, Dr. Bharatwasana showed real good data. So my sequence could be abiraterone followed by docetaxel, then enzalutamide.
Right. So I think that seems to be the which is coming out.
And obviously, sir, depends on the disease load also. Yeah.
So I think the question is, if somebody has taken docetaxel in the first line, then what is the first line option for hormonal therapy when you sort of have to for progressive disease? Is it enzalutamide or is it abiraterone? If the patient is not
Abiraterone.
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 So I think, I mean, abiraterone is used before enzalutamide unless there is a contraindication.
Yeah.
So I think we are running short of time as well. So, and the next slide, maybe, is there a next slide, please? There are several slides, I know. So I think the sequencing has become fairly clear that abiraterone, docetaxel, enzalutamide, or docetaxel, abiraterone, enzalutamide. So I think that is what I see from the panel is a consensus. So so what about a repeat biopsy? So there is NCCN says.
Sir Sahu here. Sir Sahu here. Sorry, I'm not in the panel. Can I just come in for a minute, sir?
Yeah, TP. Yeah.
Yeah, sir, only thing is that, sir, would we not be looking at the previous response to the enzalutamide or abiraterone to even think of that? Because I feel there is enough data to tell that if there's early recurrence or a lack of response, which is beyond less than 1 year to one of these agents, it won't be a good choice to repeat such agent rather than continue with the second line chemotherapy. That's the only small point which I wanted to make.
Okay, so Dr. Sahu is introducing cabazitaxel here.
No, issue is not, there is data enough to support that. That's my point. And what is the panel's view on the mutation of the V7?
Okay, so what, Abhishek, what about, is anybody doing this? Is it available? Is it relevant? I don't know. I mean, Abhishek, your comments.
Sir, I have not done it. I don't know whether it is available or not.
So if it is available, then what?
Even that then also I think I will not be doing it.
Okay. So Dr. Ankit.
No, so I've not done the test routinely, and I'm not very, to be very honest, I'm not very confident about using a paclitaxel as first line. So
no, it's not.
No, it is the question of second line actually.
Yeah,
sorry, second line. Sorry. So I don't think I'll be. I'm very confident about doing the test also.
Yeah. So Dr. Arun, and any thoughts on ARV7?
So I think the response to the hormonal therapy can be a surrogate for the ARV7. We need not test for it. I think the majority, I think a very minority initially have an ARV7, and as the treatment sequence progresses, then you develop this ARV7 mutation. So I think the response to the hormone therapy would be a surrogate. So I don't think the testing would be very beneficial.
Right. So I think Dr. Tarini Sahu, I think the ARV7 has really not picked up in our.
My point was what exactly Dr. Arun told, that if you don't have a response to the first line of abiraterone or enzalutamide, do not consider it as the other agent as the second line. Switch over to chemo. Yes. That's the only small point which I wanted to make.
Right. So therefore the answer to that question from my side would be that if somebody has not done well in the first line abiraterone, well then after docetaxel, I'd like to go for cabazitaxel rather than enzalutamide.
Exactly.
Yeah, exactly.
So I think we have
I agree with this.
We have a consensus there. So I think we're coming to the end. Maybe one or two more slides. Next slide. Basically coming to the PARP and to the MSI. Next slide, please. Next, I think we'll skip these slides. I think we covered most. I think next, please. Next slide. Next, please. Okay, so this was the, so this is the point I was trying to make. CRPC, conventional imaging studies, positive for metastasis. So they want a metastatic lesion biopsy. So do you do biopsy in a patient who's progressing? Anybody doing biopsy?
No, sir. Not
No,
doing
sir.
routinely.
Routinely, we are not doing so.
Yeah, Dr. Sahu, are you participating in this?
No, I actually don't do biopsies. I will be very frank. Except for lung cancer, I normally, or breast cancer, I normally am not very keen. But yes, I would now think about it.
Yeah. So the idea is to differentiate between, conversion into a small cell, particularly if the PSA is not high, which is commensurate with the amount of metastasis. And then of course, yes, Dr. Bharat.
Sir, if in those who are multiple refractory, this small cell incidence is as high as 30% in some of the series. So ideally, if you have a multiple refractory, it should be done, because you may have an option of platins then, sir. So ideally, we should do it, because the incidence of the transformation rate is quite high in a multiply treated patient in prostate, if you see the literature.
Sir, can I make a comment?
Yes, please. Yes.
Sir, I consider doing biopsy in CA prostate once there is high tumor, high metastatic burden and PSA is not rising in that proportion. So in that only situation I do biopsy. Otherwise, I don't. That's my take.
Absolutely, because I think that is the point I was trying to make. That if your level of PSA is,
sir, you're asking for a repeat biopsy or the front line also?
Repeat biopsy.
Repeat. That's it. Okay.
It's a repeat biopsy. CRPC, conventional imaging studies, are positive for metastasis, and they are asking for a metastatic lesion biopsy to differentiate between neuroendocrine.
Sir, one more point. Can I make a comment, sir? Because routinely we do the PSMA PET right now. I think a lesion which is not that PSMA avid would point you towards doing a repeat biopsy also. So I think that because of the technology change also, we can incorporate that as a marker.
Yeah,
so there are several pointers which could direct us to encourage us to go for a biopsy of the metastatic type. For the PSMA is not taking up, or if the PSA levels are low. So those are the definite candidates for consideration for a biopsy to look at the neuroendocrine component, and which will make them eligible for a protocol. Of course, it covered the MSI and the germline and tumor testing for HRD on the tumor, not only on the blood sample. So if somebody is able to afford, because that is what the guideline says, because you should be testing for the tumor, BRCA1 and 2 or the HRD. So I think we are short of time. We've covered a few things here. I think these discussions can go on, and I'll thank all my panelists, Dr. Sahu, to be part of the panel, and Dr. Bharat as well to participate. So thank you very much, and looking forward to seeing you next time. Thank you very much.
Thank you so much, sir.
Thank you,
so
sir.
much.
Thanks a lot. Thank you, sir. Thanks a lot.
Thank you.
Now I request Dr. Lalit Mohan Sharma sir to give his expert comment on this topic of metastatic prostate cancer. Dr. Lalit Mohan Sharma sir. Sir is here.
Sir is here. Sir has to unmute himself.
Can we move to the last session, please?
Okay. So now we'll move to the next topic of geriatric oncology. For this session, we have chairperson Dr. Dinesh Gupta. He is a consultant surgical oncologist at Narayana Super Specialty Hospital, Jaipur. And Dr. Arun Chandrasekaran, he is a medical oncologist at Astra MIMS Hospital, Kerala. So to start with, geriatric oncology is a newer and upcoming domain in the field of medical oncology. it is becoming increasingly important for us because we see a lot of geriatric patients, elderly patient in the OPD. They are different from the young and fit patient because they have multiple comorbidities. They may have poor peers. They may be already on multiple drugs, and for such patient, managing with the chemotherapy and other drugs may be actually difficult, and they require special care. So we have today our esteemed speaker, Dr. Vanita Narona ma'am. So she is a professor in medical oncology in Tata Memorial Hospital, and she's already author of multiple publications in this specific field. She, out of her special interest in the field of geriatric oncology, she has started a separate geriatric OPD also at TMH since last 2 years. And she also started a 1-year special fellowship program for in the field of geriatric oncology since last 2 years. So I think it will be our honor to hear from her in this special topic of geriatric oncology. And I request ma'am to start her session on this a new topic of geriatric oncology.
Thanks so much, Samir. Thanks, Tara and Rushabh. For the record, I actually offered to cancel this. It's really late, and I'm tired, and I'm sure all of you guys are tired. So I'll try and just offer is still open to cancel. But can you see the slides?
Yeah,
Arun, stop laughing and say whether you can see or no, yeah.
Yeah, we can see
Okay.
slides.
So I'll just start. So the topic is, age just a number. So these are the discussion points, and I'll cover as many as possible. Request to stop me in about 10 minutes or so because I don't have a clock on my screen. So how old is old? What do we actually define as old age or a geriatric population? And how common are geriatric patients in our practice? What is different about older patients with cancer? Do we really need any special tools to assess these older patients, and which specific patient needs a geriatric assessment? So to start with, how old is old? We have various global geriatric bodies, and unfortunately or fortunately, most of these global bodies define old age differently. So the ASCO guidelines defines a geriatric population as a patient over the age of 65 years. SIOG, which is European based, defines older population as 70 and older. Japan probably is the country which has the longest life expectancy, and in Japan, an older person is actually somebody over the age of 75 years. This is the map of life expectancy globally, and you can see that there are countries that have really long life expectancy, so over 85 years, Australia, Western Europe, Canada. India is somewhat in between. Our life expectancy is 70. So age is a physiological process, and it differs between individuals. But the accepted societal definition of somebody who's an older person is roughly the same as the retirement age in that population. So according to the Indian Income Tax Act, a senior person is someone who is 60 or older. And life expectancy in India at birth in 2017 was 69 years. It has been updated this year, and currently it is 70. So the average remaining length of life for a person at age 60 was 18 years. And so old age is defined in India as 60 years and older. So, and this is something that is followed by most of the people who practice geriatric oncology in India. So there is a geriatric department at AIIMS, and they also use this cutoff of 60 years and over. And in our geriatric oncology clinic as well, we use age 60 and over. In the spirit of full disclosure, when we started the clinic, I didn't know this. So we were following the ASCO guidelines, and we started using 65 and older. And then as we started learning geriatric oncology as we went along, and then we lowered the age to 60 and older. So to come to the second point, how common are geriatric patients in practice? So this is the demographics of cancer and aging globally. So 8.5% of the world's population is older, and India has 104 million older people. That's about 8.5% of the population. And there's been this massive jump of older people, and they call it this elderly population time bomb. So older age is a risk factor for malignancy, and 60% of newly diagnosed cancer patients are older, and 70% of cancer deaths happen in older people. So by 2026, there'll be 4.5 lakh men and 3.7 lakh women with cancer in the 60 years and older age population. So the proportion of older patients with cancer in the US is 54%, and very similarly in India, the proportion of persons over 60 years with cancer is 56%. So we looked at our own hospital registry data, and I used the strange time frame of June 2018 to March 2020 because that was the time when between which I analyzed our geriatric oncology clinic data. So in that time frame, we had seen at Tata Memorial Hospital, we saw a little over 82,000 patients with cancer. And of those, almost 30%, so 29% of those were over 60 years old. The bit bad statistic is that of these 23,894 patients who were geriatric oncology patients, we saw only 251 patients. So 1% of the patients who should have been seen were actually seen in our geriatric oncology clinic. Are these people different? Do they really need to be assessed differently? So what is different about older persons with cancer? So when a person ages, there is an age-related decline in organ function. So the liver has a decreased blood flow, and so there's decreased drug elimination. The kidneys are affected, so there's decreased renal function. But simultaneously, the creatinine also is low because older people have less muscle mass. So the calculated GFR may actually be deceptively normal. The bone marrow has a decreased reserve. The heart is problematic. There's loss of muscle mass because of sarcopenia. But the decline is not obvious. So when you see an older person, you cannot assess that that person has various different vulnerabilities. And older people also lack functional reserve, and they may decompensate during physiologically stressful moments, specifically during chemotherapy. There are various pharmacokinetic issues in geriatric patients. Kidney function is decreased, and so drug excretion is decreased. Liver function is decreased, but that is not to such an extent. And so we do not necessarily have to dose reduce drugs that are hepatically cleared. The distribution of drugs is markedly decreased in an older person. So the fat content doubles, but the intracellular water decreases. So there is an increased peak blood concentration for water-soluble drugs. For drugs that are lipid-soluble, there's a decreased peak concentration, but a longer half-life. And drug absorption is also decreased because there's atrophy of the intestinal mucosa and decrease of GI blood motility. So do we need special tools to assess older patients? Can we not just look at a patient and say, what is the performance status of the patient, and based on the performance status, decide whether that patient can receive therapy or not? So that brings us to the difference between chronological versus functional age. So this concept of an elderly person, that is a subjective cultural concept, and it varies between cultures. It is related to health, social, and economic factors. So the chronological age is just a factor of the number of years that the person has lived. But the functional age assesses how the person functions in daily life, and that is what we are really need to determine. So the functional age is what determines the management strategy in geriatric oncology. So aging is different for different people, and these three pictures are people who I thought, I Googled and I thought they looked somewhat of similar age. But Pierce Brosnan is 68 years old, she's 38 years old, and he's 77 years old. So markedly different ages. So bringing us to the point that just looking at a person, you cannot guess. And various investigators have done this exercise and evaluated whether clinical judgment is sufficient or do you need a geriatric assessment. And they found that definitely clinical judgment is not sufficient. So correlation between clinical judgment scores and between the geriatric assessment are poor. If you perform a comprehensive geriatric assessment in patients with diffuse large B-cell lymphoma, you cannot select between a patient who is fit and frail. Geriatric assessment is superior to oncologist clinical judgment in identifying frailty. And in hospitalized patients, if for every 100 patients who underwent a comprehensive geriatric assessment, 3 more would be alive and in their own homes, compared with if you just assess the patient routinely by usual care. And the relevance of a systematic geriatric screening and assessment in older patients with cancer, results of a prospective multicentric study. So this is really one of the key landmark studies by Keenis et al. And she found in 1,967 patients from 10 hospitals, they found that the geriatric assessment that was performed in these patients detected unknown geriatric problems in over half of the patients. So 51% of patients had problems that had not been routinely recognized in the routine clinical assessment. And when the patient was aware of the assessment results, so this geriatric assessment was done and the results were made available to the treating physician, it resulted in a change in intervention. So a geriatric assessment intervention was done in a quarter of the patients, and the treatment decision was influenced in a quarter of the patients. How about predicting chemotherapy toxicity? Can we predict chemotherapy toxicity based on our routine clinical judgment, or do we need specific tools? So this was done by the late Aarti Huria. She had developed the CARG score, the Cancer and Aging Research Group score. The bar figure on the right tells you, so this is the patient's ECOG performance status, the Karnofsky performance status, and the percentage is the percentage of grade 3 and higher toxicities. And you can see that there's really no correlation with the physician assessed performance status and the occurrence of chemotherapy toxicity. This is the CARG score. So when the CARG is a risk assessment tool that predicts what kind of toxicity the patient will perhaps develop if the patient were to receive chemotherapy. And there's a very nice correlation with the CARG score and the development of chemotherapy toxicity. In our TMH geriatric oncology clinic, we had assessed 251 patients. Assuming just an ECOG performance status of 0 or 1, so assuming these were the fit patients, we had 66% of these patients. And in all comers, we had 98% of the patients had a non-oncologic vulnerability in at least one domain in the geriatric assessment. So 66% of patients had unsuspected vulnerabilities as compared to clinician judgment based on the ECOG performance status. Which patient needs a geriatric assessment? I think this will be the last couple of slides. So there were a series of letters in our the Cancer Research Statistics and Therapy Journal. We have a section on geriatric oncology, and this was one of the letters that we received, which is, and this view is held by several people, and it was held by me as well. So if you have an older person who is physically fit, do you really need to do a geriatric assessment? The person goes to the gym daily and is completely functional and is doing some sort of work. Do we really need to do a geriatric assessment in that patient? And the answer is yes, because the geriatric assessment, other than assessing the physical function and falls of the patient, it assesses multiple other things, including the emotional well-being, comorbidities, nutrition, cognition, socioeconomic issues, polypharmacy. So it comprehensively assesses the individual, and many of these domains, if the person has a deficit in that domain, you cannot tell by looking at the person. So yes, every geriatric patient requires a geriatric assessment. And there was this very interesting commentary written in the JCO that it is time to stop saying that the geriatric assessment is too time consuming. It can be done, but it doesn't have to be done by the physician. It can be done by a nurse. It can be done by a resident. And a nurse's salary for an hour. So assuming the geriatric assessment takes you 45 minutes to an hour, the nurse's salary for an hour is $28. And that is half of the cost of a chest x-ray. So it is time that you spend evaluating your patient, and you can make a real difference. These were the vulnerabilities that we noted in the geriatric assessment in our older Indian patients with cancer. I'll leave you with this. We had extensive disabilities, and because of the limited time that we have in a busy center, we assessed all patients who were planned for chemotherapy. So all these patients were planned for chemotherapy, and they had extensive vulnerabilities. This is my last slide. I just want to make a plug for our journal, Cancer Research Statistics and Treatment. It's available online at crstonline.com. I'll end there, and I'm not sure we have time for questions, but happy to take any questions.
Thank you. Thank you very much, ma'am, for your excellent presentation. It's always pleasure to hear you when you talk about geriatric oncology. I think we don't have any questions right now. I invite Dr. Arun Chandrasekaran to give his expert comment on this topic.
Thank you, Samir. Actually, ma'am has already given her expert comments on this, so there's nothing more for me to add, but the importance with, I've seen the passion with ma'am conducts, the geriatric OPD, and I never realized it that much when I was in Bombay. But here in Kerala, where majority of our patients are above 60, we have the largest above 60% population. You have patients with multiple issues, and what I've realized is age is not a number. It's you have to treat each patient depending on their physical fitness and everything. I haven't gotten around to do the complete geriatric scoring, but for this I've done a few read-ups about it, the mini cog scale or the Huria scale. So it's something which we can all incorporate easily into our practice, and the data speaks for itself. You can definitely make a difference. Okay, thank you to the organizers for this opportunity. Thank you, everyone. I'll just hand it back to the organizers. Thank you.
Thank you, Arun, for your expert comment. So at last, I invite Dr. Tarachan Gupta. He will give closing remark and vote of thanks. Tarachan.
Thank you, Samir. On behalf of organizing team, privileged to propose a vote of thanks on this occasion. My heart fills with a lot of gratitude and respect for our distinguished faculties, chairperson, speakers, moderator, and panelists for not only sparing their invaluable time for us to grace this occasion, but also for enlightening us with valuable talks on the genital cancers. My heart goes out to thank our respected attendees and for accepting our invitation, joining this webinar, and encouraging the more of the speakers by their gusto and enthusiasm. Next, I would like to thank the torch bearer of this event, our respected teacher and patron, Dr. Kumar Prasad, for leading and inspiring us in working towards the goal of conducting this webinar. We are thankful to him for this huge support at all times. I respectfully thanks to our organizing chairperson and our leader, Dr. Bhavna, who has always lent a helping hand to us since we first thought of conducting this webinar. We know you can take shape without hand-working organizing team. It was the dedication and enthusiasm of our co-organizing secretary, Dr. Asim Samar, which made this event a huge success. And I also wish to have special recognition for our teacher, chairperson webinar, Dr. Vanita Narona, for encouraging us with her humble presence and good wishes. And conducting this webinar would have been impossible without the zealous effort of joint organizing secretaries, Dr. Rajesh Chanana, Dr. and Dr. Siddharth, who have devoted lots of time and energy for this program above and beyond. Let's not forget the backbone of this webinar, our scientific committee members and our teacher, Dr. Amit Joshi sir, and other scientific committee members, Dr. Sri Rangavar, Dr. Kaushal Gupta, and Dr. Arun Chandrasekharan, who went an extra mile and worked their tail off under the guidance of the organizing chairperson and made this dream a reality. Our thanks also goes to our sponsor of this webinar, Pfizer, Roche, and their immense support. Thank you so much, everybody. This vote of thanks would be largely incomplete without expressing my gratitude for the Horizon team and its leader, Mr. Taran Mathur and Pooja Sharma, who have been working really hard and making this a perfect event. I sincerely apologize if I have missed somebody. Thank you, all of you. Thank you, all of you.
So thank you, Dr. Tarachan, and everyone who's here. And we thanks everyone for the active participation. So with your permission, can we now close the meeting?
Yes, Tarun, we can close the meeting now.
Yes, and everyone will be receiving the link if you want to see in your leisure time. All presentations will be there. Thank you so much. Thanks. Have a safe and a good night.
Thank you. Thank you all. Thank you. Good night.